Okay, guys, so next what we'll study is the topic of raised ICP. I've already explained to you that the normal pressure in the ventricles of our brain would be in the range of about 10 to 20 millimeter of mercury. So anything more than 20, I need to go ahead with intervention. Well, why is this pressure constant? Is because the rate of production and the rate of reabsorption is equal. So let's touch upon some baseline physiology as well. What is the site of production of the cerebrospinal fluid? Then your answer would be the capillaries or the choroid plexus are responsible for production at a rate of 20 ml per hour. What is the rate of reabsorption? It is also 20 ml per hour. So therefore, the production and the reabsorption rates are equal. That is why the pressure is constant. Can you tell me, like, where exactly? You see a generic term would be that the CSF is reabsorbed from the arachnoid granulations. But then where exactly are these arachnoid granulations located from where the reabsorption would be occurring? Then your technical answer, and the anatomy teacher would have also spoken about it, would be given as the superior sagittal sinus. When you study about the venous system of the brain, they'll teach you stuff like superior sagittal, inferior sagittal sinus, sigmoid sinus, transverse sinus, like that. So superior sagittal sinus is the primary site where the CSF reabsorption would be occurring, and the rate of production and the rate of reabsorption, as I'm emphasizing again and again, is normal. Why that is important to remember is that if, for example, blood or pus, like in TB meningitis, the pus is very, very thick, so it will block the arachnoid granulations, and that is why the production will keep on happening, but reabsorption is not happening, so pressure will rise. Or if a person is having CNS bleeding, then again the same thing, the arachnoid granulations can get blocked and the pressure in the brain can rise. Now, due to rise of pressure in the brain, there would be stretching of the dura mater. Dura mater is the pain sensitive structure in the brain. So why you get headache in patients who raise ICP is because when the pressure rises, it stretches the dura, and dura is innervated by the trigeminal nerve. Like, you are comfortable with the fact that trigeminal nerve is the sensory nerve supply of the face. Motor of the face is seventh, sensory of the face is trigeminal nerve, but trigeminal also innervates our dura mater. So one more concept from physiology, the dura mater is innervated by crenulum number 5, and when the pressure in the brain will rise, then it will cause stretching of the dura, it will cause stretching of the nociceptive receptors. Nociceptive क्या होता है? That's the pain sensitive receptors of the trigeminal nerve. तो उसको headache का sensation हो जाएगा. Then there would be projectile vomiting that would be happening. Projectile vomiting और routine vomiting में फर्क क्या होता है? क्योंकि देखो, फोर्सफुल वॉमिटिंग तो दोनों होती है. प्रोजेक्टाइल इज नॉट अबाउट कितनी दूर जा रही है, राइट? हम कोई मेजर तो करते नहीं, वी नॉट गोना मेजर, राइट, हाउ फार द वॉमिटस इज गोइंग. सो प्रोजेक्टाइल वॉमिटिंग इज वॉमिटिंग माइनस नॉजिया. Minus nausea. If you ever had vomiting in your life due to food poisoning, you will realize that you start feeling pukish, uncomfortable. Then you get up, you go to the wash basin, you lean, and then you apply force, and then vomitus happens. So sometimes can be happening even while you were sitting in the bed, but then you had that pukish sensation. Now here, there is no pukish sensation. Like, I'm talking to you at the moment, and suddenly vomiting happens, and it spoils all my clothes, and I feel so embarrassed, that I vomited in front of everybody. That is projectile vomiting. So in raise ICP, the vomiting that would be happening would be without any stimulus, or without any nausea, without any warning. And then when the pressure in the brain will rise, it will also cause development of sixth nerve palsy. The sixth nerve palsy is actually called as the false localizing sign, because the problem is not in the nerve. The nerve is going through that area where the pressure in the brain is elevated, and that's why sixth nerve palsy occurs in these patients. In fact, I would like to mention another anatomy aspect at the moment that will make you realize why sixth nerve palsy is so common. In fact, before I write down the rationale, must know fact for you guys: what is the most common cranial nerve involved in raised ICP? Answer is sixth nerve palsy. Now, what is the reason? You see, if he says that what is the which cranial nerve overall would be having, let me just rephrase the language of the question, and you'll get a gist and the understanding of the question. You see, overall, the longest cranial nerve in the brain happens to be vagus, right? Vagus will innervate the rectum also, the heart also, GI tract also. So overall, vagus, is the longest cranial nerve. But if he says CRN ka matlab hai cranial nerve, if he says cranial nerve which has the longest subarachnoid course, you see, subarachnoid is the area from where the CSF is traversing. So the cranial nerve with the longest subarachnoid course happens to be the abducens nerve. And when the pressure in the brain will rise, then there would be stretching of the sixth nerve. That is why you get a diplopia on looking laterally. These patients would be having double vision on looking on the lateral side, SO4-LR6. So it is the lateral rectus muscle, because sixth is supplying lateral rectus, which is not functioning. So the question will say patient presents with headache, vomiting, and diplopia on looking laterally. These would be universal statements that would be present in all the cases that I've discussed prior to like starting the topic of raise ICP, because whether it is subrecurrent hemorrhage, whether it's going to be extradural, subdural hemorrhage, ultimately if the examiner wants to increase the length of the question, he will also incorporate findings of raise ICP. A generic statement that I mentioned earlier was papilledema is a feature of raise ICP, but then if the examiner wants to increase the length of question, you can see like the data is right in front of you. Cranial nerve with the longest subarachnoid course is answered as the sixth nerve. If I change the language of the question and he says that which cranial nerve in the brain has the longest intracerebral course, now you can see halat badal diye, just baat badal diye, that everything is changing at the moment. If I say which cranial nerve has the longest intracerebral course, then answer is not vagus and is also not going to be the sixth nerve. Then your answer is going to be the trochlear nerve. So 3 questions I've handled. Overall longest vagus, subarachnoid course longest sixth nerve, longest intracerebral is the fourth nerve, and in our case it's like the sixth nerve palsy that is happening. And then if I change the question and I say which is the most reliable symptom of a raise ICP symptom. Examination findings are multiple, like papilledema is one of the very reliable ones, but one of the most reliable symptom that you'll be getting in a patient is altered sensorium. Now, when you will examine these patients, you will get 2 very characteristic findings. One is bradycardia and elevated blood pressure. These two is a combination of what is called as Cushing reflex. Cushing reflex is actually a protective reflex. It is good to have this reflex because it maintains the brain perfusion. Let me explain mathematically why this is so. So let's look at mathematics now. I don't want you to now think like a doctor. I just want you to look at the elementary mathematics that I tell you. The formula is cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. Mean arterial pressure of you and me right now is 95 millimeter of mercury. Mean arterial pressure is calculated from systolic and diastolic blood pressure. The formula for that is systolic plus 2 times diastolic, whole thing divided by 3. The intracranial pressure upper limit is 20 millimeter of mercury, as I explained to you. So therefore the difference will be about 75 millimeter of mercury. But you see, everything in physiology is a range. So overall, if they ask you what is the normal cerebral perfusion pressure, your answer is 60 to 80 millimeters of mercury. In the light of this discussion that normal range is 60 to 80, let me write this formula once again before you. Cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. Now let us assume a person had a head injury and because of that the ICP in the brain is rising. When ICP will rise, just look at it mathematically and tell me, suppose ICP is rising from 20 millimeter to 30, then what will happen to perfusion of the brain? Obviously the mathematical value will begin to reduce. Now if you don't want this fall, if you want to prevent this fall, what we can do is that we can increase the mean arterial pressure of the patient. Let me say cerebral perfusion pressure increase from 20 to 30 and MAP increases from 95 to 105. If I increase both by 10 points, then the value will remain the same now. Yes or no? Pure mathematics. If ICP rises by 10 points and MAP also rises by 10 points, then both will counterbalance each other and the perfusion of the brain will remain normal. That is what is happening, that in patients of raised ICP, the body is increasing its sympathomimetic drive. And when you upgrade the sympathomimetic drive, the increased mean arterial pressure will counterbalance the raised ICP of the patient, and that is why there is an elevated blood pressure. Don't try to lower the BP of a person of raised ICP. If by mistake a doctor is lowering the BP of a person of raised ICP, it will cause a deterioration of a patient. It can even kill a patient because perfusion will decrease. You see, the total perfusion is based on mean arterial pressure now. It is good that the mean arterial pressure is more because it is helping in maintaining of the brain perfusion. If I by mistake decrease the MAP, I can cause even a potential death. And then is like that when the blood pressure rises, then from physiology, you know that there is baroreceptors which are present in the body. These baroreceptors will sense that the BP is rising, so they will cause a bradycardia. So don't be surprised if in a question of raised ICP, vitals may mention heart rate of the patient is 60 and the blood pressure of the patient can be like 180, 200 something. So bradycardia with elevated blood pressure can be present. Then the third finding was given as a line diagram where you can notice the patient is having the following manifestations. The first and foremost, I'm trying to show some period of hypoventilation. You can see that the breathing is becoming like this particular area. or let me just highlight it with a different highlighter. This particular area is showing hypoventilation. I'm just going to mark it once again, hypoventilation present in these patients. Apart from the hypoventilation component, you will also notice that intermittently it looked as if the guy had literally stopped breathing, because there was a period of apnea where I put the arrow as the apnea period. And then I'll just use a different marker. This particular area that I've marked at the moment, this particular area, this is hyperventilation that is happening intermittently in this person. So the breathing of this patient is called as periodic breathing, that you get a hypoventilation apnea. This causes the buildup of carbon dioxide. The most potent stimulus of the respiratory center is not hypoxia. The most potent respiratory center stimulation is carbon dioxide. So hypoventilation apnea, hyperventilation would be happening. And if I repeat this again, then the same thing is like getting replicated again and again. Again, we get a hypoventilation. Then we again get an apnea in a person. Then you again would be having a period of hyperventilation. If you compare the breathing part from where the yellow part is or where the purple part is, then I can say the depth of the breaths are relatively much more bigger. So on a comparison basis, what is happening in this chap is periodic breathing. This periodic breathing is also called as Cheyne-Stokes breathing, and this keeps on getting replicated again and again and again. In FMG exam, they had mentioned regarding another type of breathing, which I'm going to show just few seconds from now. But at this moment, the minimum that I expect you to remember is that all patients of raised ICP, when they present to us, can be having a Cushing's triad. In Cushing's triad, there are a total of 3 things that would be present: bradycardia, elevated blood pressure, and Cheyne-Stokes breathing. So point 1, 2, and 3. I'm just marking them together. Point number 1, 2, and 3 together. 1 and 2 together is what is called as a Cushing's reflex. But if he specifies the word that there is a bradycardia in the question also, there is a mention of elevated blood pressure. It is good to have elevated blood pressure, as I explained, primarily because it helps in maintaining of the brain perfusion. Then the technical word that I would like to write here is what is called as Cushing's triad. It was a all except MCQ, not a component of Cushing's triad. Answer can be like posturing. I'll describe posturing also subsequently. What is present in Cushing's triad is point number 1, 2, and 3. So the yellow marking is for the Cushing's triad. Now, at this point of time, if I don't intervene, or if the patient comes late, like in India, most of the time Indian patients would be coming late, then there's gonna be a deterioration. What I mean by deterioration is that the breathing of this patient will now become like this, I'm saying that it is a very erratic breathing that is happening in the person. It is hypoventilation, then intermittently I've shown hyperventilation also, then apnea. Like there's no pattern present. So if you compare the superior pattern with the inferior one, you can see that in the person, the pattern I can call is irregular breathing. This irregular breathing is what is called as Byard's breathing. So they can give you line diagram of any one of these. Early phase we have Cheyne-Stokes breathing, and the later part we have is a development of Byard's breathing. And the technical term for Byard's breathing is irregular breathing. At this junction, I also want to bring to your attention that in the cardiology section, I've taught you irregular pulse. That is atrial fibrillation. Irregular pulse was discussed 2 times in cardiology. One for atrial fibrillation, second for multifocal atrial tachycardia. But at this point of time, I'm not describing irregular pulse. I'm describing irregular breathing. That is Byard's breathing. So what you get from the vitals perspective is bradycardia, elevated blood pressure, and then this variation in the breathing components. And if the person is still not taken care of, or if the patient is brought late, then you would be having development of posturing in these patients. These posturing can be written as rigidity as well, decorticate and decerebrate posturing or rigidity would be occurring. Now, how in 30 seconds would you be able to identify by looking at the image of the patient given in the question? Like they'll give you an image of a patient with head injury lying in the casualty, and he will ask you that, okay, tell me, is it decorticate or decerebrate rigidity? Then you cannot differentiate from the position of the legs, because in both of them you will notice that there would be extension at the knee joint and there would be a plantar flexion happening. You can see in both of them there would be extension of the knee and there would be a plantar flexion that is happening. But if you look at the upper limbs of the patient, there's a marked difference. If in the question he gives you an image, just look at the elbow joint of the patient. In the superior diagram, you can notice that there is a flexion at the elbow joint as well as flexion at the wrist joint of the patient. So if you get a flexion at the elbow, like I'm doing at the moment, and flexion at the wrist joint, it is decorticate posturing or decorticate rigidity. On the other hand, if you are getting an extension at the knee joint, the wrists are still flexed. If I zoom in, you can notice that the wrists are still flexed, but the difference is with respect to the position of the elbow joint of the patient. So in 30 seconds or even less than that, if you have to identify, just check out the position of the elbow joint of a head injury patient. If you notice a flexion, it is decorticate posturing. If it's gonna be extension there, it is decerebrate posturing. At this moment, you'll be saying, sir, I mean, what is the importance of knowing all this? Well, decorticate posturing means that it is the midbrain that is getting compressed at the moment. Decorticate rigidity from physiology is like lesion above the red nucleus. Red nucleus is exactly in the midbrain of the patient. So like the upper part of the midbrain is getting compressed. That's why we get decorticate. What is the function of the there's a tract which is present here originating from the red nucleus that is called as rubrospinal tract. Spinal tract basically facilitates the upper limb flexures. You know what you need to understand is this facilitates the flexion of the upper respiratory tract. So the lesion is above, then this tract is still preserved. I'll say that once again. You see, if the lesion is above the level of the red nucleus, then the tract जो उसके नीचे से आ रहा है, that is rubrospinal tract, is still alive and is functioning. So you will be able to get a flexion present here. But if the lesion will go below it, then this tract will be inhibited. And if the tract is inhibited, then you can't get a flexion. Then you'll get a ulta, that is a extension present. This is a pure physiology concept that has been asked here, that like why is there a flexion in the upper limb? Because the rubrospinal tract at the moment is not compressed. What is the rubro means the red nucleus. Spinal means it's going to the spinal cord and then is innervating the flexors of the arm. So because the tract is intact, so you will get a flexion, and when it gets compressed, when the lesion goes below this, the tract will be compressed, and therefore like you get an opposite, because now flexion cannot happen. So you get a decerebrate rigidity. At this moment, from the Glasgow Coma Scale perspective also, this decorticate rigidity is belonging to the M3 category. So when you read the Glasgow Coma Scale, even the surgeon would have spoken about it. It is called as abnormal flexion. And then the person will develop decerebrate. Then the pressure in the brain will go below the level of the midbrain into the pons and the medulla. So therefore you would be having M2 coming. In M2 you can notice it is an abnormal extension that is happening. So you would have read about this Glasgow Coma Scale multiple times in your career, but I'm trying to give rationale that why do we get a flexion and why do we get an extension is because at like M3 position, the pressure is on the upper part of the midbrain. The rubrospinal pathway is still not compressed. But once it gets compressed, that means that now the pons and the medulla is also getting compressed. That is serious business, no? Because what you can understand is that present in the medulla is the respiratory center. It is the pacemaker of the respiratory center. In the medulla, we have an anatomical area which is called as the pacemaker of the respiratory center. Just like in the cardiology section, I told you that the pacemaker of the heart is the SA node. Similarly, the pacemaker of our respiratory center is called as the pre-Botzinger complex. Because this pre-Botzinger complex will get compressed, therefore person will go into respiratory failure and can ultimately die. Like I described that case, no, that lumbar puncture was done in that student and then suddenly went into respiratory arrest. So now you can understand that when they would have put a wide bore needle and did a lumbar puncture, there would have been a gush of CSF. The brain of that boy would have been displaced downwards, and that would have crushed the brain stem, first the midbrain, then the pons, and then the medulla. And because the pre-Botzinger complex is gone, the pacemaker of the respiratory center is gone. That is why a respiratory arrest would have occurred. And that is why I was teaching you that he had to be put on a ventilator and then was transported. Any patient on a ventilator, you can understand, can develop ventilator associated pneumonia. He can end up with development of a pneumothorax as well. So the message at this moment is that when the pressure in the brain rises, then the important parts of the brain will start getting compressed. And I'll just bring to your attention another very interesting point in this line diagram. If you focus here, I have shown a biconvex bleed which is increasing. So because then when this biconvex bleed will increase, it will cause a horizontal shift of the brain as well. When you look at this diagram, you can also notice that the ventricles of the brain are looking asymmetrical. Like here, one ventricle is totally squeezed. It's literally crushed because of the mass effect, and the contralateral ventricle is dilated. So what I want to bring to your attention, I'm writing point number 1 for this. This is what is called in English as like a midline shift. But the technical word, though it is written, still for practice sake, we will call it a subfalcine brain herniation. This subfalcine brain herniation that is being discussed at the moment is what is also called as midline shift and would be lots of time read by you in a CT or a MRI report in patients of head injury. That's a horizontal displacement of the brain. Now, because of gravity, there would also be a downward displacement of the brain. So I put a downward arrow to say that brain will, because when the clot will expand, it will cause a horizontal changes, it will cause vertical changes. The vertical is the brain will start getting pushed downwards also. So the technical term for the downward displacement of the brain is what is called as the central herniation of the brain or a transtentorial herniation. In fact, the better word is transtentorial, already on the slide. So even if you don't note it, chalega. But what you have to understand is that there is two types of brain herniation being told to you at the moment: subfalcine and transtentorial. And transtentorial is the most commonest type of brain herniation that occurs. There is a downward displacement of the brain. Now, where I'm putting point number three, this point number three is where the oculomotor nerve would be present. This is also the midbrain. You know, midbrain is the one which is having the oculomotor nerve. So midbrain will start getting compressed in a person. The word that I would like to use now is called as uncal herniation, not uncle UNCLE wala. It is UNCAL. That is uncal herniation of the brain. And at this point of time, the oculomotor nerve of the patient will also start getting compressed, because the oculomotor nerve will be compressed. When you shine a torch in the eyes of this patient, you will notice that the pupils will on that particular side not respond to the light stimulus. On the other side, the third nerve nucleus is okay, so there would be no issues. But on the side where the brain herniation is occurring, on the side on which the clot is present and is causing brain herniation, I'll rephrase my statement. On the side on which the clot is present and it is pressing on the third nerve nucleus, you would be having is the presence of a ipsilateral mid-dilated pupil, which will be having a sluggish reaction to light. Why this is important for you to note down is that normally in the brain, like whenever there's an injury, all manifestations occur contralaterally, but this is a same-sided manifestation that I'm telling you. It's a ipsilaterally mid-dilated pupil with sluggish reaction to light, and the technical term that they use to describe this is what is called as Hutchinson pupil. What does Hutchinson pupil tell you? That which side is the bleed present? As a doctor, I can like find out on whichever side the bleed is present even without a CT scan. Obviously, the best way to localize a CNS bleeding is to go ahead and like do a CT scan. But he says that even like without a CT scan, a doctor can identify which side is the bleeding present, because when you shine a torch in the eyes of the patient, you would have seen in the casualty all head injury, we shine a torch in both the eyes. If I notice on one side the pupil is mid dilated and is exhibiting a sluggish reaction, it will tell me that that is the particular side on which the bleed is present, and I can confirm that obviously with help of a CT scan. So uncal herniation is occurring. Now where I'm putting point number 4, the area where I'm putting point number 4 is where the cerebellar tonsils are present. They are one of the lowermost areas of the brain. The cerebellar tonsils will also get displaced downwards. When the cerebellar tonsils will go downwards, they will squeeze the medulla and press it against foramen magnum. So where I've written point number 4 is what is called as foraminal herniation of the brain. What you mean by the word foraminal herniation at the moment is that there is a downward displacement of the cerebellar tonsils. And what do the cerebellar tonsils? If you recall from anatomy, cerebellar tonsils के just आगे जो होता है वो medulla होता है. So cerebral tonsils का क्योंकि यहाँ पे inferior displacement हो रहा है, because cerebellar tonsils का inferior displacement हो रहा है, so this is gonna squeeze the medulla. And medulla is where the pacemaker or the respiratory center is located. Therefore, in these patients, what you ultimately have is a development of respiratory arrest. That is what I was saying now, that the boy had a lumbar puncture and suddenly went into respiratory distress. What happened was the sudden gush of CSF would cause a foraminal brain herniation. There would have been an inferior displacement of the cerebellar tonsils, which have resulted in squeezing of the medulla, and therefore respiratory arrest would have occurred. There are total of 4 types of brain herniation that I've described before you: subfalcine, transtentorial, uncal, and foraminal herniation. Among the 4, if they ask you to select one and say which of these is the most common type of brain herniation, then it is slightly a controversial MCQ, that in some surgery books it is mentioned subfalcine herniation, that is called as midline, but most medicine books mention transtentorial herniation, the downward displacement, as the most common variety. The last one that I would like to mention is like 2 people had a fight and एक आदमी ने पत्थर उठा के दूसरे के सिर पे मार दिया. तो पत्थर मारा सिर पे तो स्कल ही फ्रैक्चर हो गया, and the brain is jutting out. You can see brain tissues coming out through the fracture of the skull. So for this, I don't need to write it. It's very obvious. Transcalvarial. Calvarium basically means the skull. So when the skull is broken, you have brain herniation from the perspective that brain tissues jutting out of the skull because the inner and the outer table of the skull got injured. So what you have is total of 5 types of brain herniation. Among these, the third one is critical because this is the time when midbrain herniation, that means brainstem herniation has started. And when brainstem herniation occurs, that is when I know that the person can go into a respiratory arrest, and even cranial palsies would start occurring in these patients. The objective was to sensitize you to what happens when a person starts having a head injury. The manifestations are there would be development of bradycardia, elevated blood pressure, the breathing becomes irregular and erratic. And then we have point number 4, which I'm just putting in fairly. This would be development of posturing. Either the MCQ will use the word rigidity or they might use the word posturing. Both mean the same. There are 2 types of posturing, decorticate and decerebrate. First decorticate hota hai, jisme M3 bolenge, then is decerebrate, that is called as M2. Rationales for the same has already been explained to you. And now we will see, like, because the person can die, what can you do to prevent death from occurring? So the next slide will be focusing on specifically management of raised ICP. Objective is to maintain ICP of less than 20. Cerebral perfusion pressure of more than 60. Remember I told you that range 60 to 80. So that's my objective. And therefore what I want to do is first position the patient. Positioning would mean elevate the head end and keep the head in the midline. All patients of head injury should not be made to lie in the hospital bed. Half the time, this basic nursing procedure is also not followed. Like in a government hospitals, you will notice that half the time the head injury patients might be lying in supine position. That will increase the risk of brain herniation. So patients should be kept with head end elevated. Then we will put a catheter in the brain of the patient in the ventricles, and we will drain the CSF to decrease the pressure. This is what is called as ventriculostomy. For ventriculostomy, I'll just show on the slide here. This is what we are doing. We're drilling a hole and we are putting a catheter. You can see this is a intracranial pressure monitoring catheter which will be put in the ventricles of the brain, and this will help in removing the CSF because pressure in the brain is high. So if I'm saying physics now, if I reduce the volume, then the pressure will also come up. So this CSF will flow into a sterile container. And on the digital display, we can actually see the actual pressure in the brain. So you have a real-time evidence of like what is the pressure in the brain. The procedure that I'm trying to teach you is either called as ventriculostomy, or instead of ventriculostomy, it is also called as external ventricular drainage. The word is external ventricular drainage. A concern of a lot of doctors is, sir, if you will remove the CSF, will it not cause all the CSF to be lost from the brain? No. In this catheter, there is a sensor. That sensor will record the pressure. The sensor will ensure that like the pressure when it is more than 20, when the pressure is more than 20, only then the catheter will allow there's a one-way valve present here. So when the pressure is more than 20, the one-way valve will open and it will allow the CSF to collect in a collection chamber. Otherwise, like when the pressure comes back to normal, the valve will close and CSF would not be flowing out. So this procedure is what is called as ventriculostomy, or is also called as EVD, that is external ventricular drainage. This is one of the most effective methods to reduce the pressure in the brain. Like if you are able to put this catheter, this catheter has a sensor at the tip. It will record the pressure, and on the digital display you can see what is the actual pressure in the brain, and the sensor will ensure that there is a one-way valve which is present. The one-way valve will allow the CSF to flow into a sterile container, and thereby you can control the pressure in the brain. Going up in the slide, I said drain CSF via ventriculostomy / external ventricular drain. This is the fastest and also the most effective. If he says overall, what is the most effective method to reduce the elevated pressure in the brain? Then the fastest and the most effective method to lower raised intracranial pressure is ventriculostomy. I can say that in our hospitals, lots of time head injury patients come, and because the procedure is not done, patient is lying in supine position, mortality rates are high. But I said if facilities are available and if government gives us with all the kind of support, then we are able to save patients also. Most effective method to lower raised intracranial pressure should be answered as ventriculostomy. If I don't have this facility, what I can do is at least give osmotherapy to a patient, that is give mannitol or hypertonic saline, At this moment, I want to tell you that mannitol is absolutely contraindicated in a patient with active CNS bleeding. Like suppose a person is having warfarin toxicity, and warfarin toxicity is causing a CNS bleeding to happen at this moment, then the bleeding will stop because of the tamponade effect only. If I give mannitol to this patient, then the tamponade effect will be gone because I will remove the pressure, I will reduce the pressure in the brain, and the bleeding will worsen. Mannitol is contraindicated in active CNS bleeding. When you listen to it the first time, it is very shocking, sir. Like you were saying that we will not give mannitol. Yes, sir, even in extradural hemorrhage. I never spoke about mannitol. In lot of these online forums and on YouTube, I have seen a question on extradural hemorrhage by discussed by like I'll not get into names, but I've seen wrong answers being given. Like the question of extradural hemorrhage was given, and the question said, "What is the first line management?" The first line management is not mannitol. Mannitol was number A option in the question. Everybody said, "Sir, mannitol mark kiye." Like a lot of students said mannitol mark kiye, and like couple of teachers were also justifying that. तो देखो आजकल का जो concept है ना उसमें क्या है कि he says that don't give mannitol to the patient, because अगर आप mannitol दोगे तो it will rather remove the tamponade effect, क्योंकि brain में there's limited space, so the bleeding stops due to tamponade effect. Now if you will remove water from the brain, then the tamponade effect will be gone and the bleeding will start, bleeding will start worsening, or bleed will restart in a patient or will worsen in a patient. कटिंग द लॉन्ग स्टोरी शॉर्ट, आप इस सब चक्कर में ना भी पड़ो टेम्पोरल इफेक्ट क्या होता है. टेम्पोरल इफेक्ट इज प्रेशर की वजह से द ब्लीडिंग विल स्टॉप. द पॉइंट इज दैट वी डोंट गिव मैनिटोल इन एक्टिव सीनस ब्लीडिंग. एक्स्ट्राडुरल हेमरेज के केसेस में वी स्ट्रेट अवे वेंट अहेड, टुक द पेशेंट टू द ओटी एंड वी डिड द क्रेनियोटमी विद ligation of the bleeder. In government hospital, when we don't have too much of facilities and even surgery is not available, neurosurgeon is not available, so something has to be done. So people are giving mannitol to the patient. That is just because you are trying to show that something is happening. But the reality is, most effective method to lower the pressure in the brain is not mannitol, it is ventriculostomy. That's message number one. Osmotherapy, that is mannitol, is contraindicated in active CNS bleeding. Second point is, he said instead of mannitol, what can you give in the patient? Then answer is hypertonic saline. Hypertonic saline of 30 cc of 23.4% saline bolus can be given to the patient. Now the opposite of this has also been asked in the exam, that which fluid is absolutely contraindicated in patients who raise ICP. Answer is 5% dextrose. Guys, 5% dextrose, when you infuse now, it becomes a hypotonic solution, and hypotonic solution will rather cause water to go in the brain, that will worsen the swelling in the brain. So 5% dextrose is absolutely contraindicated. What can be given in the patient is 23.4% saline, or just get the word hypertonic saline can be used. And don't use mannitol or hypertonic saline in ongoing CNS bleeding due to warfarin toxicity, for example, because the bleed stops due to tamponade effect. You remove that and the bleed tends to worsen. Then is the role of steroids, glucocorticoids. Now, I did mention regarding steroids being used for management in tubercular meningitis. Well, why are you giving glucocorticoids to the patient? That is for management of vasogenic cerebral edema. Do not answer glucocorticoids in head injury, ischemic or hemorrhagic stroke in a patient. It is for that CNS infection or tumor or abscess. I would like to write it here that when do you write dexamethasone from the CNS perspective? The objective is to reduce the swelling in the brain. Swelling in the brain, vasogenic cerebral edema कहाँ पे मिलता है? So vasogenic cerebral edema can be responsible for causing seizures, and one of the causes of vasogenic cerebral edema is brain tumor. So we don't give, we are not supposed to give mannitol in those circumstances. Rather, to reduce the, patient with brain tumor is having seizures. How do I decrease the frequency of seizure? Give steroids. So brain tumor may obviously we will require surgery or chemotherapy, whatever. But because of the vasogenic cerebral edema, steroids are an integral part of treatment. Then is TB meningitis, tubercular meningitis. Because of the vasogenic cerebral edema, the person can again end up with possibility of seizures. The third aspect can be brain abscess in a patient. So these are the situations where steroids would be used. And at this point of time, again a query that comes is, sir, brain abscess में तो infection होता है, infection में तो steroid देते नहीं है. भाई मैं मानता हूँ कि infection में steroid नहीं देते, but अगर vasogenic cerebral edema है तो benefit है ना, तो we will give steroids to a patient. So in a brain abscess, obviously I'll give antibiotics also, but Dexona will play a role. The learning point is, from point number 5, steroids are to be given when there is evidence of vasogenic cerebral edema, and when they would not be given is like in head injury patients. Now, we will also do sedation of a patient and add neuromuscular paralysis, because I need to secure the airway. all patients of raised ICP will ultimately be having compression of the brainstem, and therefore the gag reflex, cough reflex, the important reflexes which prevent aspiration would be affected. So to secure the airway, I have to intubate, but before I intubate, I would like to sedate and give the patient neuromuscular paralysis. I don't want the patient to breathe on his own. I want the computer to do the breathing for this patient. You see, if person will breathe on his own and the computer will also do the breathing, rather there would be pneumothorax. खुद भी सांस ले रहा है, ventilator is also causing breath, that will cause pneumothorax in a person. So it's important to give neuromuscular paralysis, that is like pancuronium, vecuronium, or the molecules of succinylcholine, depending on the availability, can be used. And we will also be doing hyperventilation of the patient deliberately. Hyperventilation से क्या होता है कि PCO2 हम जानबूझ के कम करते हैं, because this causes malfunction of the feeder vessels which are supplying the choroid plexus. Choroid plexus, remember, is responsible for production of CSF. मैंने बोला था ना, coronal plexus produces CSF. So when you do hyperventilation, carbon dioxide washout has been shown to decrease the rate of CSF production. Again, I'm saying mathematics. If you decrease the production from, let me say, 20 ml per hour, say 15 ml per hour, what will it do to the pressure in the brain? It will, like, I put that as a question to you. If you decrease the production of the CSF, what will it cause? Will it decrease the pressure in the brain, or will it prevent the further rise of pressure? Obviously, it will not decrease the immediate pressure, but if you decrease the rate of production per hour, then it will prevent the further rise of pressure. So this is a short-term step that we can be using here. I'll repeat the rationale once again. Hyperventilation, like on the dashboard of the ventilator, you can control the respiratory rate. So on the respiratory rate, I'll deliberately keep it as like instead of 50, instead of normally is like in a range of about 10 to 16, we'll keep like 20. The rationale is that we want to cause a carbon dioxide washout, which has been shown to decrease the rate of CSF production, so it will prevent the further rise of pressure in the brain. Then we will use pressure therapy, like we can use norepinephrine, phenylephrine, dopamine in the patient. On this, the query that comes from a lot of students is, sir, you are saying that you are giving norepinephrine. Norepinephrine to cardiogenic shock mein dete hain, septic shock mein dete hain. You are giving it for raised ICP. Yes, I am using it. Why? Because I want to maintain the mean arterial pressure. Remember, I told you that formula. Cerebral perfusion pressure is a difference of mean arterial pressure minus ICP. Due to head injury, ICP is already elevated. Now what I can do in my patient is, if I increase the mean arterial pressure, then it will counterbalance the raised ICP of the patient. And what drug I can use to increase the mean arterial pressure? I can use norepinephrine in the patient, or dopamine, or phenylephrine. So pressure therapy again is something that you read multiple times. Like, when do you use norepinephrine in your patients? Norepinephrine is the vasopressor of choice for management of septic shock. Norepinephrine is also used in management of cardiogenic shock. So traditionally we read like norepinephrine in management of septic shock and cardiogenic shock. But today I've told you that we will also be using it for management of raised ICP. The rationale is in front of you. The rationale is that because the pressure in the brain is elevated, I want to counterbalance it by increasing the mean arterial pressure, and the cerebral perfusion would be maintained. These are three uses of norepinephrine. There are three uses of Dexona that have been discussed here. If in spite of all this, the pressure in the brain is not controlled, then I can go for surgery. Decompressive hemicarinectomy. I can go for barbiturate coma. I can go for therapeutic hypothermia. I can take name of a Formula 1 driver, especially boys listening to me. If you follow Formula 1 racing, you would have heard of this German driver. His name was Michael Schumacher. Michael Schumacher had a nasty crash, and in that crash, like, the injuries were so bad that he started having brain herniation, and like they were still able to save him. The crash, I think, happened in 2014. And like almost more than a decade has passed by, more than a decade has been passed by, he's still alive. In our government hospitals, head injury patient comes and dies within maybe 5-6 hours. And here, more than a decade, they kept him alive. Obviously, Michael Schumacher will never walk again, never talk again, will never recognize family member. He cannot eat, is bedridden, understandable. But at least they kept him alive, no? That is the value of life. How did they manage? What they did do separate from what we do, that they were able to save the patient, is just the use of tech or technology. So they decreased the temperature of the brain to 33, therapeutic hypothermia, cerebroprotective. They used barbiturate coma. They would have done decompressive hemicarinectomy, because all the initial steps would have been done, still the pressure in the brain would have been very, very high. So they used even second-tier therapies, which are FDA approved for management of raised ICP. I'll summarize the points once again. I'll move the slide. Any raised ICP patient, if he says, first thing is positioning, head and elevation. Step number two is osmotherapy to be done in a patient. But before you give osmotherapy, check out whether there's an active CNS bleeding or not. If there's an ongoing CNS bleeding, like due to warfarin toxicity, don't give mannitol. What is safer? Safer is putting that catheter in the brain. That is why you are noticing that in point number two, I had written that I will be going ahead with ventriculostomy or external ventricular drainage. Guys, this table that I showed to you, this is like from Harrison. He has mentioned a step-by-step approach for management of raised ICP. I said position the patient above osmotherapy is ventriculostomy. He says जहाँ पे भी facility है, use the most effective method to lower the raised ICP. That's a separate thing. If I don't have anything, I will go ahead with osmotherapy, and I will not give like steroids to a patient unless and until it is the following three situations that I've explained to you. Then secure the airway. Aspiration risk is substantially high, so I would like to sedate the patient. Neuromuscular paralysis, intubation is done. And when you start ventilating the patient, keep the respirator rate on the higher side deliberately. Why? Because you want a carbon dioxide washout. That carbon dioxide washout will decrease the rate of CSF production, and because of that, जो pressure brain में बढ़ा हुआ है, वो तो और नहीं बढ़ेगा, right? It's not that it will immediately lower the pressure in the brain, but at least it will be a temporary step. That was the point number 6 that I explained to you. Then we can use pressure therapy, and if in spite of all this, if the pressure is more, then we can go for second tier therapies. तो आज मैंने आपको 8 तरीके बताए हैं sir. I've told you 8 methods. In fact, there are more than 8 because eighth is having 3 points again. So if you look at it objectively, there are almost like 10 points which have been explained to you by which we can decrease the pressure in the brain. Our ultimate aim is to maintain ICP less than how much? 20. Cerebral perfusion more than how much? 60. So these are the strategies that are used for management of raised intraocular pressure, including I've shown external ventricular drainage ka line diagram. This is not to be confused with वेंट्रिकुलोपेरिटोनियल शंटिंग. इन एफएमजे एग्जाम उसने क्या करा, उसने ऐसा एक लाइन डायग्राम दिया था जिसमें मैं स्टूडेंट साइड की सारे कैथेटर दिख रहा था, एंड द कैथेटर वाज टनल्ड अंडर द स्किन, एंड देन ही हैड हिमसेल्फ मेंशन्ड द कैथेटर एम्प्टीज इनटू द चेस्ट ऑफ द एब्डोमिनल कैविटी. आप मेरा वाला डायग्राम देखो, वाज द कैथेटर एम्प्टिंग इनटू पेरिटोनियल कैविटी, वाज इट एम्प्टिंग इन द चेस्ट कैविटी? नो ना, इट वाज इन अ एक्सटर्नल कलेक्शन बैग. It was going in external collection bag. So this line diagram where you see the CSF is accumulating in a collection bag is EVD, ventriculostomy. But on the other hand, if he mentions that the tube is emptying, or like the catheter that has been put is emptying into the chest of the abdominal cavity, then we will call it a VP shunt. This VP shunt is what is called as ventriculoperitoneal shunting, and this is done for management of cases of hydrocephalus. One of the important causes of hydrocephalus in pediatric age group is TB meningitis. Lots of children who are having TB meningitis, because in India patients come late, so the ventricles will get super dilated, there would be a hydrocephalus that is occurring. So ventriculoperitoneal shunting किस लिए करते हैं? It is done for hydrocephalus where there's a gross dilation. The TB pus is very thick, so it will block the arachnoid granulations of the superior sagittal sinus. CSF can come but will not be reabsorbed. So these ventricles will become bigger and will keep on getting dilated. And when the ventricles will get dilated, they will put pressure on the brainstem. And the brainstem is one that will get compressed here. The brainstem is composed of the midbrain and the pons and the medulla, and once the brainstem starts getting compressed, we are in doldrums, in a sense that problem is there, no? Like this particular area that I'm marking at the moment is the midbrain of the patient, like this is the midbrain. Then this structure that I'm marking at the moment, this is gonna be the pons, and then inferiorly if I go down, this is gonna be the medulla of the patient. So midbrain, pons and medulla is where the cranial nerves are originating, and we don't want pressure on these areas of the brain because ultimately that is the nemesis, that's the end result that is occurring in a person. To prevent that from happening, we will have to go in for VP shunting, that is for management of hydrocephalus. And hydrocephalus is gross dilation of ventricles. That is due to obstruction to the flow of CSF. So the causes of hydrocephalus can be multiple. Like I will write one more pediatric cause. Like one was obviously TB meningitis. That's the topic that we're discussing. But to make you more comfortable with the topic of hydrocephalus, do read about it from pediatrics also, is aqueductal stenosis. You see, we have what is called as aqueductus sylvius. If aqueductus sylvius, which is the connection between the third and the fourth ventricle, is not there itself, aqueductal stenosis implies that the third and the fourth ventricle are not in communication, so the pressure in the brain will begin to rise. These are like situations where ventriculoperitoneal shunting would be done, and the catheter will be emptying into the chest of the abdominal cavity and not into the sterile CSF container. That was external ventricular drainage. This is management of raised ICP. I also use the word cerebral edema multiple times. So there are two types of cerebral edema, cytotoxic and vasogenic cerebral edema. How do you differentiate them on neuroimaging is that if there is always going to be like, if the word is cytotoxic, the first word is cytotoxic, so that means that the neuronal cell is swollen. Now why the neuronal cell is swollen is because of ischemia, hypoxia, seizures. Meaning of the word cytotoxic cerebral edema is water accumulation in between the neuron. Like let me say this is the neuron. So where is the water accumulation happening? It is inside the neuron. It is the intraneuronal swelling due to failure of the sodium potassium pumps. And on a MRI, this would be clearly visible, as you can see in the image, that the white matter and the gray matter, the swelling would be very characteristically present with respect to the white matter, but the gray matter would look the same. So you can see like finger-like projections in a sense that only the swelling would be present with respect to the white matter in the brain, that is cytotoxic cerebral edema. When it comes to vasogenic cerebral edema means water accumulation is not in the neurons, it is between the neurons. Like water is accumulating here, it is between the neurons. That is a vascular leak. It's due to disruption of the blood-brain barrier. So what you will notice is a uniform swelling that would be spanning both the gray matter as well as the white matter. Both cannot be separated from each other. Like normally we can see gray matter, white matter differentiation, but here the gray matter and the white matter differentiation would be lost. The minimum that I expect you to remember at this moment is cytotoxic cerebral edema means water accumulation in the neurons, and in the neurons, inside the neurons, where I put the star mark. And when I say vasogenic cerebral edema, it is water accumulation between the neurons, not in, but between the neurons. This is mainly because of damage to blood-brain barrier by TB, meningitis, brain tumor, brain abscess respectively, and the CT scan findings in both of them would also be grossly different. For cytotoxic cerebral edema, what is the main management? Then cytotoxic cerebral edema can be managed by giving mannitol to the patient. That mannitol will remove the water from inside the neurons. But if he says, how do you manage vasogenic cerebral edema? Then don't answer like mannitol. Then you have to give a drug that will decrease the permeability of the blood-brain barrier, and the drug that is used here is steroids. That's like the fundamental difference between cytotoxic and vasogenic cerebral edema के treatment अलग-अलग है. So now you can see that earlier I was using a broad term raise ICP. Meaning of the word raise ICP is that there is more, the pressure is more in the ventricles of the brain. But apart from this, another term used is cerebral edema, which is used very casually. Lot of doctors को लगता है cerebral edema raise ICP एक ही बात होती है. No, when I say the word raise ICP, it means pressure is increased in the ventricles of the brain. यहाँ पे pressure बढ़ रहा है तो उसे raise ICP बोलते हैं. अगर न्यूरॉन्स के अंदर पानी भर रहा है इनसाइड द साइटोप्लाज्म न्यूरॉन्स, देन यू कॉल इट साइटोटॉक्सिक cerebral edema. If the water accumulation is between the neurons, you call it vasogenic cerebral edema. So we have to give treatment in proportion to whatever is the issue. If the pressure is elevated here, do a ventriculostomy. If the water is accumulating in the neurons, then you start giving mannitol to a person. On the other hand, if it's going to be vasogenic, then mannitol is not effective. It does not work in removing the water from like the interstitial space between the neurons. Then he says what you should do is decrease the permeability of the blood-brain barrier by giving steroids. Next up is the aspect of cytotoxic and vasogenic cerebral edema. Lot of doctors are under impression कि cerebral edema और raise ICP एक ही बात होती है. No guys, raise ICP means that the pressure is increased in this area, that is in the ventricles of the brain where I put a plus sign. But when I mean the word cerebral edema, and that two of the two varieties, cytotoxic and vasogenic, then there is a gross fundamental difference that I'll now explain to you. Let me say this is the representation of a neuron. This is a representation of a second neuron. So if the water is accumulating inside the neurons, intraneuronal swelling, then we will call it cytotoxic cerebral edema. Let's do this again. This is a representation of one neuron. This is the nucleus. This is the second neuron, axon. And then if the water accumulation occurs in this area, that is between the neurons, that is intraneuronal, then we call it vasogenic cerebral edema. I'll repeat this once again. One of the term is cytotoxic. So that means the cell is the one of the neuron is getting affected. So the water will be accumulating inside the neurons of the patient. That occurs because of damage to the sodium potassium pump. And the reason for this most of the time will be stroke. It can be like ischemia, hypoxia, which can result in cytotoxic. I mean, the cell is swollen. In contrast, if the damage is in the blood-brain barrier, the damage to blood-brain barrier will cause water to accumulate between the neurons in a patient. So think of a vascular leak, and this would be presentation of what is called as vasogenic cerebral edema, and the treatment of both of them is different. Cytotoxic cerebral edema कैसा दिखता है? So the main feature that you will see on neuroimaging will be a loss of gray matter and white matter differentiation. So when I will be teaching you stroke also, I'll be saying this statement that loss of gray matter and white matter differentiation would be present. You can see where I put the star marks present. You can see that normally the gray and the white matter look different in physical appearance, but here there is a loss of gray and white matter differentiation is one of the key findings. And for management of this cytotoxic cerebral edema, we have to give mannitol. I mean, mannitol will remove water from inside the neurons. But if it is vasogenic cerebral edema, then I need to give a medicine that will decrease the permeability of the blood-brain barrier, and that is Dexona, that is steroids that would be given. You can notice that in this particular area, where I put the star mark at the moment, only the white matter is involved. The gray matter appears to be relatively spared. So you can easily differentiate between vasogenic and cytotoxic cerebral edema on the basis of CT scan finding. What is the finding of cytotoxic cerebral edema? Loss of gray matter and white matter differentiation. Uniform black area or hypodensity is seen on a CT scan. In vasogenic cerebral edema, it is water accumulation not inside the neurons, but it is between the neurons. And for management of this, steroids are given. How steroids will work is that they will reduce the permeability of the blood-brain barrier. So there are three things that I've taught you at the moment. If the pressure is more in the ventricles of the brain, that is when you need to give like ventriculostomy and decrease the pressure, that's one of the most effective methods by which the pressure in the ventricles can be reduced. But if he specifically mentions the word cytotoxic cerebral edema, then you will say, I will give mannitol to the patient. And if he says that there is a vasogenic cerebral edema due to TB meningitis or due to a brain abscess or due to seizures or due to like brain tumor in a patient, then we have to give Dexona to the patient. Let's look at the basic physiology once again. In cytotoxic, where is the swelling present? It is in the neuron, inside the neuron, where I put the plus sign. That is where the water is present, intraneuronal. In contrast, when you think in terms of vasogenic, the water accumulation is between the neurons. So these are a couple of fundamental things that I would like you to understand. And now we will focus on a relatively easier topic, that is that of headache. Overall, the most common type of headache is what you and me can also have, that is a tension type headache. But if it changes the word secondary headache, then it is usually a systemic infection like meningitis, which can cause like a raised ICP, stretching of the dura mater. I repeat again, overall the most, he may write the word primary headache or generalized cause of headache, tension type headache, not migraine, not migraine. If he says what is the most common cause of secondary headache, systemic infection. When it comes to migraine, the mediator for this is at the moment to be remembered not as serotonin. In older books it used to be mentioned serotonin, but now the main mediator behind this is CGRP. CGRP stands for calcitonin gene related peptide. This calcitonin gene related peptide is the neurotransmitter that causes irritation of the nociceptive receptors of the trigeminal nerve, and trigeminal nerve is the one which innervates the dura mater. So you get sensation of headache in a patient. Most of the time it is one-sided. It is most of the time a hemicrania. I repeat again, the calcitonin gene related peptide causes stimulation of the nociceptive receptors in the dura, and this results in perception of headache in a patient. Some cases of migraine will begin with aura. Aura would mean like in the visual field, zigzag lines can be present. The patient is saying like I could not see clearly and there was blurring of vision in the morning, and then the attack started. When the attack will start, the nature of the headache will always be given as pound. Pound would mean it would be pulsatile headache. Migraine is usually a one-day attack. Like, the person will take the medicine and he will sleep most of the time. The minimum duration of an attack of migraine is about 4 hours. The upper limit most of the time is up to, sometimes migraine attacks can go up to like maybe 2 or 3 days also. Upper limit is about 72 hours, but average is about 24 hours. Average is 24 hours. So most patients would be having like one attack in a day. I will also teach you cluster headache in which multiple attacks will occur. I said in migraine, minimum duration 4 hours, maximum duration about 72 hours. If migraine attack is lasting more than 72 hours, then we use the word status migrainosus. Just like in asthma, we use the term status asthmatica. Similar spirit, we use the word status migrainosus if the attack of migraine is lasting more than 72 hours. Average duration of attack is within 24 hours. The attack will disappear. Patient will say that I want to, make the room dark. Patients of migraine, they are like affected by bright light. So they say, I switch off all the lights, I make the room dark, and I just sleep. And after taking a painkiller, and I wake up fresh. So it's pulsatile. It is a one-day attack. Lots of time, the migraine features are most of the time the headache will be unilateral. It can be bilateral, but like unilateral gives more credibility to diagnosis. It will be associated with nausea, though in some cases even vomiting can be happening. And D would stand disabling in character. This is one of the most like important diagnostic criteria, because this young lady, migraine is more common in young females. So this young lady is saying that, I'm having a headache and I just want to sleep, give me a painkiller. So his mother is saying, why don't we go and see a doctor? No, you keep on complaining of headache every single day or every alternative day. So she says, no, I don't want to go. Her mother is like, you are saying of headache, no, let's go and see a doctor. She says, sir, I don't want to go. Ma'am, mom, I don't want to go. So his mom is asking, why? I mean, you are having headache now. Why do you want to go and see a doctor? She says, like, fine, we'll hire an Uber, we'll hire a taxi, we'll go. But when the taxi will go over, let me say a speed breaker, if there's going to be like a bumps on the road, every time this patient will shake her head like this and say, even if I move my head, no, my headache worsens. So she says, how do you expect me to survive the journey to the doctor? Because Indian roads are potholed roads. So she says, every time the taxi will go over a bump, I'll get like as if my head will explode. So in these patients, the neck movements, most of the time, neck movements will worsen the severity of headache in a patient. She will say, when I will take the painkiller, I will feel better. Then I'm okay. Then I'm ready to go to show to any doctor you want. But at the moment, I'm not in a capacity to see a doctor. Disabling in character means that even neck movements will worsen the headache. Disabling in means that also, like this lady, she got a notice from a HR department saying that you take so many leaves from office. So your EL is over, CL earned leave, CL casual leave, everything medical leave is over. So we are going to fire you from the job, or you go on half pay or without pay job. So like she's saying, I'm having financial deficit also, like she's having financial problem because of her headache problem. So disabling in character. Or let me say, this young girl, she's unemployed, she's a college student. Her attendance is short. Her professor is saying, no, we'll not let you sit in the exam. Your attendance is 10%. 10% attendance. Professor is saying, like, beta, like, how can we allow university rules say 75% attendance? Even if I fake it, I can't increase from 10% to 75%. So, like, disabling a character means from the professional perspective, personal perspective. Personal would mean like patient is wanting solitude. In India, houses are small. Her brother is watching India-Australia match at full volume and she can't tolerate that sound. In migraine, you will notice there would be phonophobia. There would be photophobia present in a patient. Aversion to light, aversion to sound would be present. So POUND is one mnemonic that helps you remember the manifestations, pulsatile in nature, one-day attack, unilateral nausea, and disabling. For disabling, I gave multiple examples. Disabling could be from the perspective of like if you and me are sick, we can just put headphones in our ear, close our eyes and listen to some relaxing music. Here patient says, I can't tolerate light music also. I can't forget about loud music. She says, I can't even tolerate relaxing music. I can't switch off the bright lights. They are making me feel uncomfortable. I want to sleep. And if I move my head like this, my headache tends to worsen. So POUND, you have to remember if 4 out of 5 are present. This is a very old mnemonic, but still does the trick for MCQs. If 4 out of 5 is present and more than 5 attacks are present per year, then we will say that the person is suffering from migraine. Migraine is a clinical diagnosis. The most efficacious triptan is not sumatriptan. It is rizatriptan. Use the nasal spray of it and you will notice very quick results within few minutes. If you give sumatriptan, the result will come after 1 hour. The effectiveness will be visible after 1 hour. So he said, what is the most efficacious triptan? Rizatriptan, given with the help of nasal spray. Then triptans, they basically cause vasoconstriction and they're not given in patients with pregnancy and heart disease. In case the person is mentioned to be having atherosclerotic cardiovascular disease, or instead of atherosclerotic cardiovascular disease, coronary, he may not write atherosclerotic cardiovascular disease. Examiner can write words like coronary artery disease. Examiner can write peripheral arterial disease. Then we will use lasmiditan for management of these patients. This drug has been specially developed in those patients who are having concomitant problems like prinzmetal angina. Like for example, it's a lady, she's 55 years of age, and she's having migraine, and she's also having prinzmetal angina. When I will give her triptan, then her headache or migraine will improve, but her prinzmetal angina will worsen. Or if it's a smoker and he's having peripheral arterial disease, he's having migraine at the moment, when I will give triptan to the patient, his headache will improve, but his peripheral arterial disease will worsen. The blood supply to the toes will become lesser. So we are supposed to then use lasmiditan for these patients. And then for the prevention part, obviously the standard drug for prevention obviously is propranolol. But propranolol needs to be taken as like a tablet daily, and most patients, the compliance problem will always be there. So he will ask you in the exam, what are those once a month injections? These injections are designed in such a fashion that they block the action of CGRP, that is calcitonin gene related peptide. The month a month injections are like galcanezumab and fremanezumab. Galcanezumab and fremanezumab are those new drugs which are given. These are like, like I can say, like in asthma, no, they always ask about benralizumab, dupilumab, omalizumab, like the biologicals, right? So that in the same spirit, even they are asking about these once a month injections that can be given to prevent attacks of migraine. Obviously routine drugs are there. Propranolol is there, verapamil is there, uh, we can use flunarizine, amitriptyline, valproate, gabapentin. There are so many. So I've not written the name of all of them because you already know about them from pharmacology. But that once a month injections are required. Then is the miscellaneous MCQ. Onabotulinum A injections are used for management of again migraine. And then we have a score to assess the severity or like the disability with migraine. It's called as MIDAS. MIDAS full form is Migraine Disability Assessment Score. The word is disability assessment score. There the questions would be like, how many months per day do you, like, you have to miss your office? How many days per week do you have fight with your family members because of your headache? How many days per week are you calling up your office and saying that you need a leave? So what we are trying to do is assess disability, because disability just does not mean physical disability. It means work related disability, financial losses to the patient also. So MIDAS score value more than 21 means that patient will need prophylaxis. It means it's a severe attack that is occurring in a patient. So these are questions on migraine that you're supposed to remember. And now I will change the perspective, and instead of a young female, I'll begin with a male. When this male patient came to my clinic, he was like, very restless, and he said, I need to see the doctor right now. Maybe I was busy in some consultation, so I told my nurse that, okay, like, ask the patient to wait. So he's fighting with her. He's saying, no, no, I want to see the doctor right now. So finally, because he was creating a lot of commotion, so I got up and I, like, I went outside. I said, why are you making so much of noise? I will see you, man. Like, I never said I'll not see you. He says, sir, I need treatment right now. This guy is keeping his one hand on his eye. I said, what happened? He says, I feel as if somebody is drilling a hole in my eye with a drill machine. I said, what? He says, I feel somebody is drilling a hole in my eye with a drill machine. He says, doctor, pain is so bad that I literally feel like taking out my eyeball. Horrible thing, no? He's saying, मेरा enucleation कर दो. He obviously will not say enucleation. He will say मेरा आंख निकाल दो सर, इतना पेन हो रहा है. So the pain rating would be 10 on 10. So I asked him to remove his hand. When he removed his hands were wet with the tears, because there's a lot of watering from the epiphora. There would be a lot of bulbar congestion that will also be noticed. The eyes may be red on that particular side. You may notice that the eye may be bloodshot red, bulbar congestion. And then the person will also be having nasal congestion. Nasal congestion because tears bahut zyada na. So like this, he is doing nasal congestion because tears will travel through the puncta from the nasolacrimal duct. You know that we have a puncta from where the nasolacrimal duct enters into the nose. So the tears will travel to the nose also. So he'll be doing this sniffing kind of an action, that is nasal congestion. So when you read about a male with a retroorbital pain with this epiphora, bulbar congestion, nasal congestion, multiple attacks, 1 to 8 attacks per day, the duration of attack minimum is 15 minutes, last up to 180 minutes. And the reason why I call it cluster headache is because if the attack will started yesterday at 3 o'clock in the afternoon, it will start at 3 o'clock in the afternoon today also. Most attacks of cluster headache, they follow a particular cyclic frequency that they will occur only for few months in a year. Like attacks don't occur all through the year. They are like few months of a year, like maybe in the spring season, maybe in the autumn season, and the at the timing of the day at which they will occur in the spring season will also be fixed, like at 3 o'clock, then at 9 o'clock, then at maybe 12 o'clock in the night when he's planning to sleep. So he says like every few hours I am having to take medicine, I'm having to take painkillers, and still the painkillers don't work, because in this particular case you have to give sumatriptan. Most of the time the person will be like so bad that they will not be able to take a tablet. So what you need to do for these patients is give a injectable sumatriptan. A lot of these patients, you can ask them to purchase that injection of sumatriptan and keep it with themselves handy so that they can take this medicine. The first line management for this was asked in FMG exam. That is not sumatriptan, it is high flow oxygen. That is why I rephrased my data. How high flow oxygen works, like the textbook says, it is not known, but high flow oxygen at a rate of 12 to 15 liters per minute has been able to control these episodes. And if he says how can you prevent this episode from occurring, then here don't answer propranolol. Here you have to answer verapamil. Here you have to answer verapamil for prevention perspective. Now, there are a couple of more aspects which are to be remembered. These three common errors that I'm mentioning is mainly for those students who are preparing for any threat exam, for FMG exam. This slide, the one is sufficient. The 3 pointers are for like INISET and like NEET PG exam. The question will begin with stabbing, orbital pain, and tearing, and like the attack duration will be given to be anywhere between 5 to 240 seconds, not in 15 to 180 minutes. It would be seconds. So if he gives you this history that multiple attacks, like he says somebody is like taking up some pointed object hurting me in the eye again and again, the duration of pain is like pain few seconds goes away, pain few seconds goes away. If says somebody poked me, again pain come, then again poked me. So that kind of a description where pain is occurring for few seconds would be called as sun CT. That is short lasting. Unilateral nuciform headache with conjunctival injection and tearing, where the duration of attack would be like 5 to 240 seconds. Then will be a question in which he will say patient is having one-sided headache, so you will think in migraine, and like the headaches are occurring every 10 minutes. Like in migraine, I said it's like a one-day attack. Now you take a painkiller and you sleep. Here he says that patient's headache responds to indomethacin, but it occurs every few minutes. Then it is paroxysmal hemicrania. Then this is I can call this data as migraine variant. I can call this as a migraine variant. In migraine, what will happen is that the attack will occur when you take a painkiller, the attack will go away and patient will wake up fresh. I mean, you and me, everybody, in their whole lifetime, at some point of time might be having off and on migraine attacks. And that's a very common neurological reason why patients go to a doctor. But here it's like recurrent attacks per day lasting for 10 minutes repeated unilateral headache attacks. That is paroxysmal hemicrania. And then for cluster headache, I've already explained to you, that it would be like patient will be very restless. Patient will be like, in cluster headache, the person will not be able to, if you and me are having headache, like if somebody is having migraine, no person will sit. Most patients will sit or will sit like this and say, I'm having headache. Cluster headache, the pain is so bad. That guy was saying to me that, doctor, I feel as if somebody is drilling a hole in my eye with a drill machine. The receptionist of mine had told him, please sit down. He was standing and fighting with her. He was pacing left, right. He's moving. He's saying, just do something, just do something, just do something like that. No. So like I had to, stop my consultation. I came out. No, normally you will not like interrupt your consultation. You will like finish one patient, then attempt to the other. Here, this guy was literally creating a ruckus. And my receptionist was trying to calm him down, right? Now, no, please sit down. The doctor will attend to you, sir. Please just give me 10 minutes and we will attend to you. He says, no, I'm having so much of pain. And he's like, he's refusing to sit down. So pain is so bad. In migraine, patient says, don't disturb me. I can't move my head. I can't walk. My headache gets worsened when I walk. Here, person would be like aggressive restlessness that would be seen. So here, like I gave a description, but I did not mention the word restlessness at that point of time. But that's a presentation of cluster headache. Additional points that have been added is if the duration of attack is like given in seconds, it is sun CT. If it's gonna be migraine-like presentation, but it's on a recurrent basis with response to indomethacin, then it is paroxysmal hemicrania. In migraine, like you take a painkiller and you go to sleep and you feel relatively refreshed. So that's one of the important aspects of headache. And these two CTs that I've described before, you must know facts, guys. Loss of gray matter white matter differentiation. This is a feature of cytotoxic cerebral edema. And if you see the edema component only in the white matter of the brain and not in the gray matter of the brain, you can see those finger-like projections that are drawn to show that it is exclusively limited to the white matter. Then you will say it is vasogenic cerebral edema, for which steroids are given. For cytotoxic, it is mannitol that is given. And for raise ICP, obviously, like, we had to discuss multiple things ranging from decompressive hemicraniectomy to pentobarbital coma to external ventricular drainage. So like those concepts are like the core neurological aspects which I expect you to remember, and the examiner expects you to remember. That's why I'm asking you to remember. Okay, guys. So next we talk about stroke, that is cerebrovascular accident. In cerebrovascular accident, you see the normal blood supply of the brain is about 55 to 60 ml per minute. Ischemic stroke occurs when the brain blood supply goes to less than 20 ml per minute. Usual reason for this is, this guy is not aware, but most of these patients are having a arrhythmia by the name of atrial fibrillation. Atrial fibrillation is a condition in which there is stasis of blood, and because the atria are twitching, so stasis of blood will contribute to clots, and these clots can then embolize out. So therefore, most of the time, like what is happening in atrial fibrillation is cerebral embolism. I can call the clots dancing in the atria as dance of death, and the clots are going out of the heart and they're going into the brain and thereby contributing to cerebral embolism in a patient. So the question will say 60-year-old man, he is having diabetes, hypertension, atherosclerotic risk factors, developed sudden onset face deviation and arm weakness for the last 3 hours, and CT scan shows a dense MCS sign. He can mention CT scan is normal also, but here I have tried to be very classical. You can see a huge clot which is occluding the middle cerebral artery. So we call it a dense MCS sign. This is the initial finding. In the same patient by 6 hours, what you will notice is that this clot will not be seen. Then you will be able to see a very clear-cut hypodensity. Which is present on the CT scan, and this is the main evidence of the fact that the patient is suffering from ischemic stroke in a person. In hemorrhagic stroke, it will be a hyperdensity, and in ischemic stroke, it would be a hypodensity present. So he will give you this presentation, patient presented with sudden onset face deviation, arm deviation, and he says like, what is the door to imaging time? So the door to imaging time should be kept under 25 minutes. If patient comes, according to the American Stroke Association guidelines, if patient comes to the hospital now, we should be doing CT scan preferably within 25 minutes. Then there is a question which said, if CT scan is normal, what is the next best investigation? Then I can do a CT angiography, because see, if CT scan is normal, that's a possibility. Know that at the moment, if patient comes very early, then CT scan can be normal, but CT angiography will still help me identify that there is a large vessel obstruction which is present. At this moment, I want to make it clear before you that ideally for detection of ischemic stroke, what we should do is diffusion weighted MRI, but MRI takes a very long time to be done. The more, like America, they have all the facilities in the world, still they don't answer MRI as the investigation choice for stroke, because MRI takes a very long time. CT will give you a report very fast. So though for early detection in the first hour, I can do a diffusion weighted MRI also, but if I waste my time doing an MRI, I'm basically losing billions of neurons. So I don't want to lose gray matter, I don't want to lose white matter. Therefore, what I will do is, instead of doing a DW MRI, I'll just ask the radiologist to push contrast and I'll be able to identify a large vessel occlusion. The window period for management of acute ischemic stroke is the same, 4.5 hours. Don't get influenced by those reels that say 9 hours now. I will tell you 9 hours also. The query that I get is straightforward. No, sir, now it is 9 hours. By window period is still the same. We should treat stroke as early as possible. That's a different thing than when patient will come late to us. I will be ready to treat the patient. Earlier guidelines were we don't do thrombolysis up to beyond 4.5 hours. Then it increased to 6 hours. Now we do it up to 9 hours only. So the message here is window period for management of acute ischemic stroke still remains the same. Don't get influenced by these Instagram reels. They look very sound. They'll say now the most important guideline is that thrombolysis done up to 9 hours. I will tell you who are those patients where it can be done up to 9 hours. Earlier the patient comes, the better is the prognosis. Now, with the light of this data, I would like to mention priorities of acute stroke consultation. First and foremost, in acute ischemic stroke in a patient, we will assess the airway. Like obviously, any patient who's comatose, we need to assess the airway because patient can end up with aspiration. So if required, we can put a Goodell's airway. Like if the tongue is falling backwards, and I need to, I mean, by meaning the assessing of the airway is that if the patient can still able to ventilate himself, but I don't want the tongue to fall backwards, so Goodell's airway can be put up, and I'll check the blood pressure. So I'll teach you ABC here. In A, I want you to remember that it is not like, A is airway, that's understandable. B is not breathing, it is blood pressure. You will check the blood pressure of the patient. If blood pressure is more than on admission 185 by 110, blood pressure more than 185 by 110 is a contraindication for thrombolysis in a patient. We will not be performing the process of thrombolysis. The drugs that are used are like tenecteplase or elteplase. Yes, now tenecteplase is also approved. The advantage of tenecteplase is it's a bonus fibrinolytic now, so it can be given directly in the IV cannula. With elteplase, you need to set up an infusion. It is given over 1 hour. Tenecteplase is what can be given as a bolus fibrinolytic. So BP should be less than 185 by 110. If the blood pressure of the patient is more than this value, then it is a contraindication for thrombolysis. At this moment, I want to say that some questions in your exam are so simple that they will not get into all this technical jargon. They will just say patient presented with symptoms, and then he will himself say it is acute ischemic stroke, or he will give you a hypodensity mentioned in the theory or the text of the question. And then the question will say that on admission, the BP is 200 by 100. What is the first step? Your answer will be lower the BP. And what drug can you use to lower the BP? You can use nicardipine, you can use labetalol. So lots of time in the questions, deliberately the BP value will be given to be higher. So you see, if a doctor will do thrombolysis in somebody in whom the BP is high, then the chances of brain hemorrhage will be more. No? One of the biggest side effects of thrombolysis is bleeding. I'll just write it here in a separate color in red. The biggest side effect of thrombolysis, thrombolysis is not a joke now. The biggest side effect of thrombolysis is development of bleeding. By bleeding, I don't mean a chota mota bleeding. It can be brain hemorrhage also. Because the biggest side effect of thrombolysis is bleeding, you cannot do thrombolysis in patient where blood pressure is elevated to more than 185 by 110. Higher BP means more chances of bleeding. Higher BP means more chances of bleeding. So the bleed will worsen. I'll say that again. Thrombolysis का side effect क्या है? Bleeding होता है. और हाई बीपी में अगर आप थ्रोम्बोलाइज कर दिए इन हाई ब्लड प्रेशर पेशेंट, इफ यू थ्रोम्बोलाइज द ब्लीडिंग विल इंक्रीज इवन फर्दर. द बेसिक रूल ऑफ मेडिकल साइंस इज फर्स्ट टू नो हार्म. To treat one problem, I can't create a new one for my patient. No, so thrombolysis is absolutely contrary to BP is more. Your answer in question where BP is elevated would be, I will first lower the BP using nicardipine or labetalol, and later on I can proceed with like thrombolysis in a patient once the BP comes down. So A is airway, B is blood pressure. I've told you the importance of the blood pressure value, the critical cutoffs. Then is clearly established the time patient was seen normal. Talk to his wife, talk to his like son or daughter, because you want to identify, was it wake up stroke? Earlier we never used to treat wake up stroke. Wake up stroke means patient went to bed last night, woke up with features of stroke with face deviation and arm weakness. Then we never knew. Now we treat wake up stroke. So one update is wake up stroke is now being treated. Earlier when patient used to suppose somebody got up in the morning, went for a morning walk, went for yoga. When he came back, when he was sitting at the dining table, he had stroke. So his wife is telling, sir, he was sitting at the dining table, and that is when there was this weakness that was elicited in this person. So we have to establish the time the patient was last seen normal. Was it last night? When husband and wife said good night to each other, and both old people, like they retired people, 70 years of age husband, 70 years of age wife. So husband and wife went to bed, and in the morning the husband was found to be having features of stroke. Or was it that he woke up in the morning, he went for his yoga, he had his morning cup of tea, and that is when the symptoms were seen. And after A, B and C, airway, blood pressure, and clearly establishing a time, we will calculate NIHSS value. What is NIHSS value? That is National Institute of Health Stroke Scale value. This National Institute of Health Stroke Scale value is an online calculator which helps us like standardize the diagnosis of stroke. See, as a doctor, I can make a mistake. I can confuse a TIA with a stroke. So he says, to be sure, there's an online calculator. You have to feed in the data there. Like, face deviation, arm weakness, cranial nerves, peripheral nervous system examination, sensory system examination. So you have to do a detailed neurological examination, not from your mind, but as given in that algorithm. There's a checklist. So you have to click on all the findings that you get or all the deficits that you're getting. And in the National Institute of Health, NIH, all of you know, is National Institute of Health. SS stands for stroke scale value. If this value is more than 5, it is like the patient is eligible for endovascular therapy. Endovascular therapy is that we will go inside the brain blood vessel, we will catch the clot in one piece and extract it. Endovascular therapy is what is also called as mechanical thrombectomy. Either the word written is MT, mechanical thrombectomy, or it is called as endovascular therapy. If you're listening to me carefully, I had told you that in patients who are suffering on a hemorrhage, we go for endovascular coiling. But here I'm not saying endovascular coiling. I'm saying we will put a stent in the brain blood vessel and we'll extract the clot in one piece. So either we can be going ahead with a mechanical thrombectomy / EVT, or we can go for thrombolysis. Now, who are those patients where you will do thrombolysis, and who are the patients who will be doing mechanical thrombectomy is what I will tell you subsequently. And as I've explained to you that if he himself says CT scan is normal, the next best investigation is not a DWMRI, it is a CT angiography. As far as thrombolysis is concerned, it should be done within 4.5 hours. In the latest update, they mentioned that we can do thrombolysis up to 9 hours from the last known well. I mean, last known well means that what was the time when the patient was last seen normal in image selected patients. That is, we have to do imaging of the patient, that is CT perfusion study. So ideal answer of window period still remains the same. It is 4.5 hours. If he says the word extended window in the MCQ, only then the answer will be given up to 9 hours. And this 9 hours is valid for two situations. One is wake up stroke, and second is, as I said, if the patient had like onset of symptoms but ambulance took a little extra time to come to the hospital. So 4.5 hours to 9 hours from CT perfusion, if there's a salvageable tissue, that is when we will be doing thrombolysis in a patient. The update is that we still do it ideally in 4.5 hours. Upper limit of 9 hours are valid for wake up stroke or like CT perfusion showing that patient had manifestations and ambulance reached late or patient came late. Now I want to introduce you to what is called as Mercy. Mercy is the brand name for mechanical embolus retraction in cerebral ischemia. Earlier, we were using the word Mercy, mechanical embolus retraction in cerebral ischemia. Then they started using the word mechanical thrombectomy. And then they started using the word endovascular therapy. All basically mean the same. Guys, the word mechanical embolus retraction in cerebral ischemia, you can look at the terminologies, they all mean the same. Examiner will use them like interchangeably, so you have to be comfortable with these terminologies, that is mechanical embolus retraction in cerebral ischemia / mechanical thrombectomy / if I say the word endovascular therapy or EVT in a patient. Let me just highlight the data once again. The word is why am I emphasizing on this is because a lot of guys, they get overwhelmed with the terminology. I'll draw a parallel here also. In cardiology, I've told you now that we have third degree heart block. It is also called as complete heart block. It is also called as Stokes-Adam syndrome. एक ही चीज का तीन नाम है, complete heart block, third degree heart block and Stokes-Adam syndrome. वैसे ही ये एक ही बात है. Endovascular therapy बोलो, mechanical thrombectomy बोलो, only thrombectomy बोलो या Mercy बोलो. When is it done? It is done for large vessel obstruction, which can be visible on CT angiography involving the middle cerebral artery and the internal carotid artery. But now, so update hai, that update is we can do it for basilar artery occlusion as well. Earlier, mechanical thrombectomy or Mercy was being done exclusively for only IC and proximal MC occlusions. Now we are doing it for basilar artery occlusion. अब किसके लिए करेंगे? तो mechanical thrombectomy can be done in the first 6 hours also in those patients where thrombolysis may be a contraindication. Ideally देखो हम क्या कर सकते हैं? We can first do thrombolysis to soften the clot. And after softening the clot, we can do Mercy because thrombolysis does not work in all the cases. So it says when patient is in the CT scanner only, and you diagnose that he's having ischemic stroke, give tenecteplase when he's in the scanner only. This will soften the clot, and then you can take the patient in the cath lab, and in the cath lab, you can be doing mechanical thrombectomy. So the standard of the care nowadays is that we are doing two things for our patient. That is, one, we are softening the clot using medicine, and then we are doing a thrombolysis in a patient. Like current guidelines are that mechanical thrombectomy, पहले क्या था, mechanical thrombectomy is only done for late presentation between 6 hours to 24 hours. Now he says that first 6 hours में भी अगर patient को patient hospital में आ जाता है, तो you can give like tenecteplase if patient is eligible. But अगर पेशेंट का बीपी बढ़ा हुआ है and BP is not coming down, you will not then do thrombolysis. Straight away take the patient to the cath lab and do a mechanical thrombectomy. I hope that makes sense. I said patient came with acute ischemic stroke. How do I know ischemic stroke? CT scan findings are there. If BP is elevated, if it will come down by nicardipine, I can, first give tenecteplase to soften the clot and then do a mechanical thrombectomy. But suppose the blood pressure does not come down, तब क्या करेंगे? तब we can do straight away mechanical thrombectomy in a patient. So MT can be nowadays done even in those patients in the first 6 hours who are like not candidates for thrombolysis, and obviously up to 24 hours stroke can be treated. How long? If he says stroke can be treated up to, the answer is 24 hours. In fact, for this first 6 hours where mechanical thrombectomy can be done, I'll give you one more example. I will make you practice contraindications to thrombolysis. One of the though it's already on the board, practice with me. If a patient is having sustained BP elevation more than 185 by 110 despite treatment, like I have already given nicardipine, I've already given lipitalol, and still in the patient the BP is not coming down, then I cannot do thrombolysis. So what I will do in the patient if he comes in the first 6 hours or up to 24 hours, mechanical thrombectomy. Let's do it again. Patient is on warfarin. If a person is on warfarin and is having bleeding diathesis, his international normalized ratio is more than 1.7, तो मैं thrombolysis तो नहीं कर सकता. If I do thrombolysis, bleeding in the brain will start. So what will I do? Mechanical thrombectomy in a patient. I will mention a mnemonic in this data that I'm sharing with you in like about 3 minutes from now. At the moment, just be patient and hear me out. The next contraindication is like the patient is having a major gastrointestinal tract bleeding. This gastro bleeding did not happen today. It occurs in the previous 3 weeks. Like this particular patient was having peptic ulcer disease and he had a vomiting of blood, that is hematemesis. He even had hematochezia because of extensive passage of blood. If somebody had GI bleeding in the previous 3 weeks and if I do thrombolysis today for ischemic stroke, then obviously I will treat ischemic stroke, but uska jo GI bleeding hai dobara se start ho sakta hai. The basic rule of medical science is first do no harm. Let me say it once again. This patient had a head injury about 2 weeks ago. The patient had a recent head injury and that was a brain hemorrhage that he had suffered from. So now he is better, but today he had a ischemic stroke. So when I will treat ischemic stroke, obviously ischemic stroke will be treated, but जो head injury है वो तो उससे bleeding दोबारा से चालू हो जाएगा. तो I cannot do a thrombolysis in this patient. Or he had a recent brain hemorrhage. Recent head injury और recent intracerebral hemorrhage में देखो hemorrhage word बार बार repeat हो रहा है. Even gastrointestinal bleeding is also hemorrhage, bleeding diathesis is also hemorrhage. So he will write the word hemorrhage in different ways. Like one more I'm writing is recent MI. If patient had recent MI, he will be on probably warfarin. Like this guy had a full thickness infarction and then he had a LV aneurysm. So he's already on warfarin and warfarin will contribute to INR to be elevated. गाइस यहाँ पे जो निमोनिक है कॉन्ट्राइंडिकेशंस टू थ्रोम्बोलाइसिस का उसको बोलते हैं स्टॉर्म. वो स्टॉर्म कैसे याद करना होता है? सो अल्फाबेट एस से पहले प्रैक्टिस करते हैं. फॉर अल्फाबेट एस इट वुड बी दैट द पर्सन इज हैविंग अ सस्टेन्ड ब्लड प्रेशर एलिवेशन मोर देन 185 बाय 110. ब्लीडिंग डायथेसिस में टी से पकड़ लेंगे. आफ्टर इट्स अ निमोनिक ओनली, सो डायथेसिस टी वाला. Then is gastrointestinal bleeding ka O, then is recent head injury or recent brain hemorrhage, and M is the M of myocardial infarction. So STORM is a mnemonic by which you are able to remember contraindications to thrombolysis. और ये जितने भी contraindications to thrombolysis हैं, इन सब में फिर करेंगे क्या? In all these contraindications to thrombolysis, he will then ask you, what will you do? So you will say nothing. By nothing, I don't mean that you will not do nothing. Like earlier, we never used to do anything, right? But now for contraindications to thrombolysis, हम क्या करने वाले हैं? STORM वाले patients में, we will take them for MT, that is mechanical thrombectomy. So this is an important data, guys, which is to be remembered. That is contraindications to thrombolysis have been discussed at the moment. I'll just rephrase my statement. When do you do thrombolysis? Ideally within 4.5 hours, and after that we can take the patient in the cath lab for mechanical thrombectomy. Ideal situation. Patient came early, we softened the clot and took him into the cath lab and did a mechanical thrombectomy. Best way, combination of both the strategies being done. Patient came late, 4.5 to 9 hours, I can still do a thrombolysis in a patient and then take him for mechanical thrombectomy. So MT is becoming the standard of care. Just like in MI, it is percutaneous coronary intervention that is the standard of care. Similarly, MT is becoming the standard of care, and now is being done not only for proximal ICA or MCA, it is gonna be mainly for like these situations. At this moment, I also want to bring to your attention that अगर किसी patient को small vessel stroke है, in small vessel stroke there is no role of mechanical thrombectomy. For small vessel stroke, it is only gonna be thrombolysis. We will destroy the clots which are present in the small vessels. We can't reach up to the small vessels. So MT is only for LVO. MT is only for LVO, large vessel occlusion. छोटा ब्लड वेसल के लिए तो थ्रोम्बोलाइसिस ही करेंगे. तो इफ ही हिमसेल्फ सेज इन अ क्वेश्चन स्मॉल वेसल स्ट्रोक व्हाट इज द इंटरवेंशन, योर आंसर इज ओनली थ्रोम्बोलाइसिस. Don't assume that MT is done for all cases. I'm saying large vessel occlusion. ICA बंद हो गया. So first I will soften the clot with thrombolysis, then go for MT in a patient, and mechanical thrombectomy can be done up to 24 hours. So stroke can be treated up to 24 hours. So these are a couple of data points which I want you to remember. As far as thrombolysis is indicated in, like, this, I'll make it much more broader in discussion. Thrombolysis is done in cases of ST elevation MI. Thrombolysis done in cases of acute ischemic stroke. Thrombolysis done in massive pulmonary embolism. There are 3 indications for doing thrombolysis: cardiology, ST elevation MI; neurology, acute ischemic stroke; and then is massive pulmonary embolism. Thrombolysis is contraindicated in, then just use English. Though I've given rationales in cardiology, non-ST elevation MI में we don't do thrombolysis because, as I explained to you, it's a platelet-rich clot, it's not a fiber-rich clot. Thrombolysis is contraindicated in hemorrhagic stroke. If already there is bleeding in the brain, and if a doctor by mistake will do thrombolysis, then it will worsen the bleeding in the brain. I mean, इतना फनी क्वेश्चन तो उसने एफएमजी एग्जाम में पूछ लिया कि भाई किस में थ्रोम्बोलाइसिस नहीं करेंगे, आंसर था हेमरेजिक स्ट्रोक. है, मैं स्टूडेंट्स वर लाफिंग कि सर क्या पूछ रहा है इतना आसान सा, कि एवरीबॉडी वेंट इन पेपर की, पता नहीं क्या हाई-फाई कंसेप्ट पूछेगा. ही आस्क्ड कि थ्रोम्बोलाइसिस नॉट टू बी डन इन, आंसर है हेमरेजिक स्ट्रोक. भाई वी डू इट इन इश्केमिक स्ट्रोक. अगर किसी को ब्लीडिंग है एंड इफ आई डू थ्रोम्बोलाइसिस देन द ब्लीडिंग इन द ब्रेन ऑफ द पर्सन विल वर्सन. सो नॉन ST elevation MI, hemorrhagic stroke. Then is going to be plain pulmonary embolism. If he just says the word plain pulmonary embolism, we shall be using strategies like heparin or enoxaparin for management. But in massive pulmonary embolism, we will have to do thrombolysis in a patient. Then the additional point that I explained to you was if the systolic BP is more than 185 by 110 despite a treatment, guys, that is the important statement. A lot of guys just miss this point. If blood pressure will come down with nicardipine or labetalol, then you don't need to go ahead. Like if BP will come down, you proceed with thrombolysis. But if BP is elevated despite the treatment, that is when thrombolysis would be contraindicated in a person. So these are a couple of like contraindications. In fact, मैंने इससे ज़्यादा बोले हैं. I mentioned that storm thing, so I'll make you practice this verbally at the moment. Try to do this with me. S is sustained BP elevation, already discussed. T would be standing for bleeding diathesis. O is for gastrointestinal bleeding, R is for recent brain hemorrhage, and M is for the recent myocardial infarction. Those are contraindications for like thrombolysis, and I made it multi-system at this particular point of time that तीन ही बारी thrombolysis indicated: ST elevation MI, AIS, and massive pulmonary embolism. If he says what is the window period in which you should start thrombolysis in a case of ST elevation MI, it is 12 hours. If he says what is the reperfusion window for acute ischemic stroke ideal, then answer would be given as 4.5 hours. If the word is ideal, it is 4.5 hours. Golden period for MI, as discussed in cardiology, is the first hour because of the risk of ventricular tachycardia, ventricular fibrillation. And what are the drugs which are approved for thrombolysis at acute ischemic stroke? Then it is tenecteplase as well as riteplase. I would like to here mention the word extended window. If he specifically says the word extended window, then your answer would be given as up to 9 hours. That is valid for patients of wake-up stroke, and that is also valid for, like, even if it is not wake-up stroke, I said selected patients on basis of CT perfusion studies, because ambulance reached the hospital late or like the patient came to the hospital late, that is when these interventions can be done. So this is like a must-know information at the moment. Now I'll talk about certain common errors for the topic of stroke. So next up are very simple and straightforward questions. The first one says hemiplegia is due to involvement of. Options are like anterior cerebral, middle cerebral, posterior cerebral, and vertebral artery. You are aware even from anatomy that area 4 of the brain is called as the motor area of the brain, and that motor area is supplied by M, that is middle cerebral artery. So if this artery gets occluded, then opposite side body paralysis would be present. That's called as hemiplegia. Then comes the aspect of small vessel stroke, which is written as lacunar stroke. Lacunar stroke is involvement of ultra chotu blood vessels. Like large blood vessel stroke would be like involvement of the internal carotid artery, middle cerebral artery. But middle cerebral artery के बाद में होती है lenticulostriate artery. After lenticulostriate artery, we have what is called as penetrating arteries. So if we are having lipohyalinosis, what is lipohyalinosis? It is younger brother of atherosclerosis. Just you are comfortable that atherosclerosis can involve the large blood vessels. उसी का जो छोटा brother है, that is lipohyalinosis, that will cause narrowing of these ultra chotu blood vessels, and therefore person will be developing small vessel stroke. I'll repeat again. Large vessel stroke involves which blood vessels? Internal carotid artery, middle cerebral artery, and we can do a mechanical thrombectomy there, where we can put a stent and we can like remove the clot in one piece. But इतना छोटा blood vessels के लिए तो we don't have any device available. So for small vessel stroke, there is no role of any mechanical thrombectomy. We will have to do only thrombolysis in this patient. So small vessel stroke or lacunar stroke occurs due to lipohyalinosis, which is younger brother of atherosclerosis of the penetrating arteries. Risk factors for large vessel stroke and small vessel stroke are same: diabetes, hypertension, smoking, hyperlipidemia. The standard risk factors that you read for heart disease are also causes of large vessel occlusion. They can also cause a small vessel stroke in a patient. Now this green structure that is shown here before you is what is called as the internal capsule. Internal capsule is that area of the brain from where all the fibers, I mean corticospinal pathway is traversing. Corticospinal pathway controls each and every muscle of our body. So suppose if I'm smiling, or if I'm sad, or if I'm angry, then all the muscles of my face are controlled through the posterior limb of the internal capsule. In the internal capsule posterior limb, we have fibers which are controlling our face, arm, and legs. So this is a crude diagram that I have shown. And now I'm showing these chotu blood vessels. These chotu blood vessels are basically supplying the areas related to the posterior limb. And if these blood vessels will get blocked, if these blood vessels will get obstructed due to a thrombus, or like person is having atrial fibrillation. So atrial fibrillation can small chotu clots, that is dance or death I was speaking. So those chotu clots can go and they can cause a physical obstruction of these ultra small blood vessels. So as a result of this, if these blood vessels will get occluded, you can see then person will develop face weakness, arm weakness, trunk weakness, and subsequently a leg weakness in a patient. So the technical term that I wanted to use here was pure motor stroke. One of a question that was having an anatomy / a medicine based orientation was that pure motor stroke occurs due to involvement of, then your answer will be this is the anterior limb, this is the posterior limb. Pure motor stroke occurs due to involvement of the posterior limb of the internal capsule. And what I've also shown before you is very chotu blood vessels that got occluded by, that's why sometimes CT can be normal, because these chotu clot or occlusions cannot be picked up by help of a CT scan. So what I showed was atrial fibrillation, that is the commonest arrhythmia in clinical practice, is responsible for the commonest variety of stroke. And the minimum I expect you to remember is that pure motor stroke occurs due to involvement of the posterior limb of the internal capsule, which has been shown here in green. Internal capsule kahan pe hota hai? To it is present adjacent to the third ventricle, that is the, like we have lateral ventricle, we have third ventricle and the fourth ventricle. So this is present adjacent to the thalamus and the lateral ventricle of the brain. Manifestations can be pure motor stroke, pure sensory stroke, dysarthrian clumsy hand syndrome, ataxic hemiparesis. But the most important one that is usually asked in the exam, he does not ask you the 4 variants of small vessel stroke. He will mainly ask you about this term, pure motor stroke occurs due to, then your answer would be it is due to involvement of the blood supply of which area? The answer is posterior limb of the internal capsule. This involvement of chotu blood vessels is called as lipohyalinosis. Don't use the word atherosclerosis here. That is for large blood vessels. Now in the brain there are different areas, like we have frontal lobe, parietal lobe, temporal lobe, and occipital lobe. So what I'll do next is draw a crude diagram before you, where I'll be showing like different areas of the brain. If they are involved, different manifestations can be occurring. Like for example, if I take up dominant parietal lobe, dominance and handedness are opposite. Like most of us are right-handed people, so just raise your right hand. If you are a right-handed person, the dominant part of your brain is left. Now, what is the function? Keep your hand on your left side. What are the functions of the left side of your brain? It helps you in getting directions. Like suppose you are using Google Maps, then Google Map will say go right 100 meters and then turn left, or he says like you take two red lights and then you turn right. So that left and right orientation is basically mediated by the I mean, you are able to understand the left and the right side. You are able to follow Google Maps because of the left parietal lobe. Then present here is also the speech area. We have Wernicke's area and Broca's area. I'll talk about Broca's and Wernicke's separately, but I just want to say that speech gets affected if the person's left side, that is the dominant part of the brain, is affected. In simple English, I'm saying if person's left middle cerebral artery will get blocked, then person will develop aphasia. Similarly, calculations like 2 plus 2 is 4, 2 plus 3 is 5. We don't have to think about it. No, it's very easy to do. That is because of the function of the left parietal lobe. Now, suppose my left parietal lobe will get damaged. Then what are the manifestations that I can be developing? One you can understand right from this line diagram is that I will lose calculation. I will lose ability to do calculation. So if you read a question that begins by saying patient is having development of acalculia, then immediately it should register in your brain that which blood vessel is getting involved. Left middle cerebral artery that supplies the left parietal lobe, and dominance is opposite to handedness. So let's do it again. Right-handed people, dominant part of your brain is left. If a left middle cerebral artery gets occlude, you get acalculia. Then you will not be able to speak, that is development of aphasia, and you will also develop inability to follow directions, like you have to go left versus right. So people who are having like damage to their dominant parietal lobe, what is the dominant parietal lobe of you and me? Left-sided. That will cause manifestations like aphasia and acalculia. On the other hand, if suppose my right middle cerebral artery gets blocked, then that is called as non-dominant parietal lobe. देखो सारा गेम यही है कि first you should be clear what is dominant and what is non-dominant. Dominance is opposite to handedness. If you are a right-handed person, dominant part of your brain is left. Manifestations are aphasia, acalculia, inability to follow commands, or like inability to follow command routine tasks. No, like I say, okay, start noting, put your hand on your left. That is again a command that I gave you. So that is a function of dominant parietal lobe. If non-dominant parietal lobe is damaged, then person will be developing neglect. Neglect would mean that he will eat only from half side of the plate, or when he will shave only one half of the face, and he will not do shaving of the remaining half of the face, or he will eat food from only half side of the plate only. Then if I ask you to draw geometrical shapes, like if I say, doctor, draw this geometrical shape in your copy, then I don't need to tell you now that this is a triangle, this is a star. You can easily understand this is a geometrical shape. If a person is having damage to the non-dominant parietal lobe, then he can draw these geometrical shapes. That is what is called as constructional apraxia. Constructional apraxia means that patient will be not able to draw geometrical shapes. That is loss of visuospatial skills. Similarly, if you ask the patient, okay, show me how you wear a shirt. So you and me can wear a shirt easily, but these patients would be having difficulty in wearing a shirt. That is dressing apraxia. So the words to be remembered is aphasia, acalculia. Features of dominant parietal lobe damage. Non-parietal lobe damage apart from neglect will be having constructional and dressing aphasia. Based on this, you will attempt questions like the question will say patient's right middle cerebral artery got occluded. What will not be seen? So if right middle cerebral artery is getting affected, that means it is the non-dominant parietal lobe that is getting affected. So what will not be seen will be aphasia. As I said, aphasia is a feature of left middle cerebral artery getting involved. I hope it's clear, guys. Let's do it again. In right-handed people, dominant part of the brain is left, and the left middle cerebral artery of your brain is supplying the dominant parietal lobe. So if dominant is affected, aphasia, acalculia. MCQ is right MCA stroke will not result in which of the following. So options will be neglect, constructional apraxia, dressing apraxia, and aphasia. Aphasia will be the answer in that particular case. Then is a very smart question that they gave in the paper. He said patient was instructed by the doctor to button his shirt. The question was not that you were asking him to wear his shirt. If he is not able to wear a shirt, that is dressing apraxia. When you are giving command to somebody, like I ask you, doctor, can you put your hand on the left side of your parietal lobe? Can you button your shirt? If I'm giving you commands and you can't follow the command, then it is damage to the dominant parietal lobe. So here the question is patient cannot button his shirt when requested. And you said which part of the brain is affected, then I explained to you cannot follow commands is a feature. Cannot follow commands is a feature of damage to the dominant parietal lobe. Let's do this again. Suppose I give a shirt to the patient and I say, okay, show me how you wear a shirt. That is not I'm demonstrating anything to him. Now I'm just saying, show me how you wear a shirt. He's struggling. That means damage is the non-parietal lobe. But suppose he has worn a shirt or I assisted him wearing a shirt, and now I said, okay, show me how you button a shirt. No, so you put a button like this. This guy is not able to do that. That is his inability to follow the commands. Then an answer would be given as like damage to the dominant parietal lobe. And neglect, I've already explained to you, that is like he's eating from like only half side of the plate, or like maybe he's shaving half side of the face. The question in the paper said that which symptom of stroke does not need treatment. Obviously, if there's spasticity, I will give drugs like baclofen to reduce the spasticity. I will be doing physiotherapy in the patient. I will be doing speech physiotherapy in the patient. But for neglect, I don't need to do anything. No, neglect is like a blessing in disguise. I'll put it like this. If I suppose I develop paralysis due to my non-dominant parietal lobe damage, and I'm neglecting one half of my body, then like it's at least I'm not thinking about it. No, suppose your body's one part is not moving, you will keep on thinking, oh man, why did this happen to me, why did God give me curse? But neglect is one condition that does not need treatment. Like for spasticity, you can give drugs which will ease off the muscle spasticity. You can do physiotherapy, speech physiotherapy, walking physiotherapy, so that patient is able to improve his quality of life. But for neglect, like there is no treatment that is required. Then we meet so many people in our life. We don't remember everybody's name and face now. We don't remember everybody's name at least, right? I'll say like this. You meet so many people in your life. There might be some people you may meet only like in your school days. Today at a railway station or at a bus stop or maybe at the airport, you came across somebody who was your classmate. You may not remember his name immediately, but what will come to your mind will be the memory of his face. So prosopagnosia is impaired face recognition. It is seen due to posterior cerebral artery stroke involving the occipitotemporal lobe. And meaning of the word prosopagnosia is, the question was prosopagnosia seen due to involvement of which blood vessel? P for prosopagnosia, P for posterior cerebral artery stroke. This means impaired face recognition. Like I said, we mean so many people in our life. We may not remember everybody's name, but we tend to remember people by faces. And in this case, they would be impaired face recognition. Forget about remembering like friends. This guy will not even remember his son and daughter. Like his son and daughter is crying in front of you. Sir, my dad behaves so strange when I go in front of him. He's looking at me like as if he does not know me. Perfectly right. PCA stroke causes prosopagnosia due to involvement of the occipitotemporal lobe. And the last question on this slide is pinpoint pupils. Normally we read about pinpoint pupils with opioid overdosage, but there will always be hypothermia and there would be a hypoventilation present. In this particular case, it is a hyperthermia that is present with pontine stroke. Let me just highlight this once again. If you get a question which begins by saying that person is having pinpoint pupils, then you need to keep your mind open for either pontine stroke or opioid overdosage. If the question mentions that the person is having development of hypothermia also mentions that there is respiratory depression and the respiratory rate of the patient is reduced, versus a question that says pinpoint pupils are associated with development of hyperthermia, body temperature is elevated, the guy is also having chain strokes breathing, or is just saying the word that the respiratory rate of the patient is increased, then the answers will vary. Pinpoint pupils, if is mentioned with hypothermia and decrease in the respiratory rate, then you will say that my patient is suffering from, right? There's a respiratory depression also given. So you will say that I will be testing the urine of this patient for street drugs. Street drug would be like heroin. So opioids overdosage is responsible for this presentation. But if he says pinpoint pupils with hyperthermia, chain strokes breathing, then you will say I will be doing a CT scan in the patient because probably the person is suffering from a pontine stroke. So you can easily identify on the basis of vitals that would be given in a question. If he mentions hypothermia with respiratory depression, opioid overdosage. If he mentions hyperthermia with chain stroke breathing, it is a pontine stroke. The next question that I'll discuss actually came in INISET exam. He gave a line diagram like this, and you could see this area which is called as paracentral lobule. It is taken to be a part of the frontal lobe only. This paracentral lobule is taken to be part of the frontal lobe only. This paracentral lobule ensures that a normal person is able to hold his bladder. Like for example, you went to the washroom and the washroom was locked from inside because somebody else was using it. So a normal person can hold the bladder. A normal person can hold stool. When the washroom will become available, person will go, no, like suppose you're going by flight and you went to the washroom, it was written like, when you use the washroom, like that light comes on, no, so it knows that the lavatory is occupied, so person will hold his bladder, and when the lavatory is available, person will empty the bladder. So frontal lobe of our brain ensures that we are able to control our bladder and the rectum. Also frontal lobes plays a role with walking, like you are able to program your gait. Like suppose I say to you that okay, it's a break time, like suppose let's assume it's a recorded class, let me say it's a live class. So I say to you, okay doctor, this is break time, so you will keep your pen pencil and you will go out, have a tea coffee, come back and then listen to me again. But if a person is having frontal lobe damage, then his walking will be affected, his programming of gait will be affected, and we will get some abnormality which is called as magnetic gait. Magnetic gait implies person will walk as if the feet are stuck to the ground. So frontal lobe damage causes following manifestations. One is magnetic gait. The person will walk as if the feet are stuck to the ground. In multiple choice question, instead of writing the word magnetic gait, because the moment a doctor is made to learn this fact that magnetic gait is a feature of frontal lobe damage, everybody is able to remember it. So some MCQs of the previous years were using the word gait apraxia. When I say the word gait apraxia, the examiner thinks that you will mix it with dressing apraxia and the constructional apraxia that I was explaining. I hope you remember that when I was describing dressing apraxia and constructional apraxia, they were manifestations of non-dominant parietal lobe damage, that is the right side of the brain. But magnetic gait or gait apraxia is a feature of frontal lobe damage, along with urinary incontinence would be present. And you will also notice that people who are having frontal lobe damage will also become very aggressive. If somebody is having head injury to the frontal lobe, now you will also notice that person, when he will recover, there would be antisocial personality, like this patient might misbehave with you, or this person will start taking off his clothes in front of everybody in a lift. His daughter and son are so embarrassed, sir, I did not understand what is going on with my dad. Like people were complaining, he वो ना कपड़े निकाल दिए उन्होंने लिफ्ट के अंदर ही. That is antisocial behavior would be present. So antisocial behavior, urinary incontinence and magnetic gait are features of frontal lobe damage. Minimum that I expect you to know right now is, if you read the word aphasia and acalculia, that is dominant parietal lobe damage left side, keep your hand like this, aphasia acalculia bolo. If the right side of the brain parietal is affected, then you will be having neglect, and along with that there would be dressing and constructional apraxia. These geometrical shapes cannot be drawn. If the person is having damage to the temporo-occipital area, then recognition of friends would be lost, recognition of son and daughter would be lost, that is prosopagnosia in a patient. And if frontal lobe is damaged, then the person will become antisocial. There would be urinary and stool incontinence and a magnetic gait. And in the paper, like he did not show a diagram, like he did not say frontal lobe damage. There was this diagram given of the paracentral lobule, which is again a part of the frontal lobe only. This is the medial side of the brain that was shown, and he said what are the manifestations given in the patient, except, so the fourth option in the question most of the time would be like from the parietal lobe. Then is a question which said patient is having left-sided face weakness and arm weakness for last 1 hour. BP is 160/100. So we can start thrombolysis in a patient. Here like the query of lot of people was, sir, 1 hour was written. So is it a transient ischemic attack? भाई देखो जो transient ischemic attack होता है ना, that I'll be teaching you subsequently, symptoms resolve by 1 hour. Symptom upper limit is 24 hours, but if it's a TIA na, symptoms will begin to resolve. In this particular patient, like the right arm weakness in the patient is present for 1 hour. Even if in this question he says CT scan is normal, CT scan can be normal in patients of small vessel stroke, because that, large vessel stroke, understandably we will get manifestations, but in a small vessel stroke the CT scan can be normal also. So we can start thrombolysis. Don't answer aspirin in this case, answer is start thrombolysis. Then for the next question, I had already given you a heads up that oral contraceptive pills, if they're having estrogen more than 30 microgram, आजकल जो लेटेस्ट जनरेशन वाली OCP पिल्स आती है ना, उन सब में ईस्ट्रोजन की जो मात्रा होती है, द वैल्यू इज ऑलवेज लेस देन 30 mics. इन ओल्डर जनरेशन दे वर लाइक मोर देन 30 mics. They've been discontinued because they used to cause features like stroke. It used to cause thrombosis of the superior sagittal sinus, thrombosis of the inferior sagittal sinus, that is cerebral venous thrombosis, that is CVT. The question can begin here by saying thunderclap headache. A lot of guys who read the question casually say, sir, thunderclap headache लिखा तो मैं subarachnoid hemorrhage mark कर दिया. By question में there was no nuchal rigidity given. Nuchal rigidity has to be given for you to say that the person is having subarachnoid hemorrhage. If he just begins by saying that patient is a female, she is taking OCPs, she is having thunderclap headache, and then she developed paralysis of her legs, and he says what is the diagnosis, then answer is not gonna be answered. Though thunderclap headache is given, your answer is not subrecurrent hemorrhage, your answer would be cerebral venous thrombosis, and because it's a venous thrombosis, then you will not be giving like thrombolytic drugs, then you will be using heparin in a patient. The next one is an FMG exam question. The question said mitral stenosis patient develops weakness in the left arm. देखो, mitral stenosis is the condition in which the left atria will become dilated because there is an obstruction present in the mitral valve. The dilatation of the left atria will result in structural damage that will trigger a arrhythmia by the name of atrial fibrillation. Due to atrial fibrillation, there can be formation of clots, and these clots can go out of the heart, they can go in the brain of the patient and can cause development of weakness in the arm. Like suppose the clots are going and are involving only this area, that is like the area supplying only the arms, right? It's not a necessity that the clot will go in that area which supplies the face fibers. It might go to that area where only the arm fibers are getting affected. So the patient is having arm weakness. The symptoms had improved over 10 days because of physiotherapy, but the point is this patient is having stroke, that is cardioembolism. If symptoms of the patient had resolved by 24 hours, suppose this question said patient's symptoms had resolved by 24 hours, then I will not call it a stroke or a cerebral embolism. Then I will say that the person is having a transient ischemic attack. But because symptoms resolved over 10 days, so minor stroke tha, mini stroke tha, that I mean the stroke involved small blood vessels, but then it got like, because the person had symptoms lasting for 10 days, that is why it is a stroke. And if it was improving within 24 hours, that's the cutoff, then I will say transient ischemic attack. Then in atrial fibrillation, do I need anticoagulation or not? Because all patients of atrial fibrillation should be started on warfarin to prevent such catastrophic events of arm weakness or face weakness or leg weakness to occur. So there's a scoring pattern that I've described in cardiology section also, that is called as CHAD S2 VSE score. In CHAD S2 VSE score, I'll say the factors verbally, kya yaad karna, that I'll tell you. C is congestive heart failure. H is hypertension, A is age, D is diabetes mellitus, S2 is stroke history. S2 is stroke history. Why S2 is 2 marks for stroke history? Because like that's more dangerous. VA is vascular disease, A is age again. Age is coming 2 times, and SC stands for sex category. They will not ask you the full form. I'll just say it once again. Go slow with me. Congestive heart failure, hypertension, age. S2, D is diabetes mellitus, S2 stroke history. S2 is given 2 marks because it's more important in the scoring pattern. VA is vascular disease like peripheral arterial disease. A is again the age, and SC stands for sex category. I want you to appreciate that in this CHAD S2 VSE score, age is coming 2 times. One for age more than 75 years, second time is age 65 to 74 years. Like for age more than 2 years, you are 75 years, you are giving 2 points. And for age group between 65 to 74, you're giving 1 point. So I just wanted to bring to your attention that normally in a scoring pattern, one parameter is present only once. All scoring patterns, one parameter comes only once. In your entire medical curriculum, this is the only score where like one parameter will be coming twice. That is, age will be ascribed 2 points as well as 1 point depending on the age group 1. And second, I want to say that the second parameter which is given 2 points here is the stroke history. And in transient ischemic attack, I'll speak more in detail about this. But if somebody is having a transient ischemic attack, TIA, will he develop a stroke or not? If I have to calculate the percentage of chances of stroke occurrence, then it is ABCD2 score. What I've tried to explain here is how does a doctor decide whether warfarin should be started or not in a patient of atrial fibrillation. CHAD S2 VSE score, and the score turns out to be like 2 or more than 2, we have to give anticoagulation in a patient. But if somebody had a transient ischemic attack, will he develop stroke or not? To predict the future risk of stroke, that was the language of the question. To predict the future risk of stroke in a patient, the score that will be used is called as ABCD2 score. The parameters of ABCD2 will be discussed in like next coming minutes. And now I will be describing hemorrhagic stroke to you, where this guy with hypertension has developed a sudden onset face, arm and leg weakness while eating breakfast at the dining table. The BP of this guy would have increased. I mean, one of the leading causes why do you have is a development of hemorrhagic stroke. The number one cause of hemorrhagic stroke in a patient should be remembered by you as hypertensive crisis. The BP of this patient would have become more than 180 by 120. Not saying 185 by 110. Hypertensive crisis defined as blood pressure more than 180 by 120 with evidence of target organ damage. If it is not hypertensive crisis, the guy could be having warfarin toxicity. Like if warfarin is given in extra dosages than what is recommended, then brain hemorrhage can occur in a patient. Or this is a young guy, he got an invite from an unknown account on Instagram that there is a rave party going on in Gurgaon farmhouse. He went to the rave party, the drug peddler gave him drugs, and the guy took too much of drugs. Cocaine overdosage can again result in hemorrhagic stroke in a patient. So these are certain reasons why, like, brain hemorrhage could be occurring in a patient. Hypertensive crisis, warfarin toxicity, cocaine overdosage can result in development of hemorrhagic stroke. The manifestations would be very extreme, and there would be a hyperdensity that would be seen on a CT scan. I will draw a line diagram before you to explain this. Like, I would suggest you to draw with me so that you are able to relate to this relatively better. This is the lateral ventricles of the brain. This is the third ventricle. These are the temporal horns as have been shown in the routine diagram. Now, the anatomical structure that I'm making now before you is what is called as the caudate nucleus. This, if it is affected, you get a chorea. The next anatomical structure that I've shown before you is what is called as thalamus. Thalamus is called as the pain relay structure of the body. It's the pain relay center in the body. Then the basal ganglia that I'm showing at the moment on the lateral side, this is called as putamen. And if you go a little medially to the putamen, the anatomical area would be called as, the white area is called as globus pallidus. In fact, this will help you in like the part 1 of NEET PG or paper 1 in FMG exam, where how they ask neuroanatomy nowadays is that they put arrows at the respective areas. And now I would mention that internal capsule. Yes guys, I spoke about it earlier also. Na? This internal capsule is having an anterior limb, it is having a posterior limb, and that posterior limb is where the fibers controlling the face and the arms and the legs would be present. Like, this is a line diagram that basically represents the basal ganglia and the internal capsule. And now I want to say that the most common site of brain hemorrhage, the most common site of hemorrhagic stroke is the putamen. Overall, the most common site, though brain hemorrhage can occur at any area of the brain, but overall the most common site of brain hemorrhage happens to be putamen. So I will distort this diagram now, because if there will be a bleeding occurring in this area, I'll show in gray. If the bleeding will be occurring in putamen, then this bleed will increase, and when this bleed will increase, it will press on the fibers which were controlling the face. So face paralysis was occurring while this patient was sitting on the dining table. When the bleed will increase further, it will press on the fibers that would be affecting like the trunk area and then the leg area also, and very soon this person will develop opposite body paralysis. This is what is also discussed even earlier as a pure motor stroke in a patient. So what I just want to bring to your attention is that this is almost identical to the CT scan that is shown before you. So the CT scan image in this, if I put data here, this is left and this is right. The bleed is present on the left hand side. You can see a hyperdensity. What I've shown at the moment before you, when the area is black, we say hypodensity. That is a feature of ischemic stroke. The area that is white is called as hyperdensity. So the final diagnosis of this particular patient is that this man has had a left-sided intracerebral hemorrhage. Instead of writing the word hemorrhagic stroke, he will use a more technically appropriate terminology. Left-sided intracerebral hemorrhage is present. And the question will say, what is the first line management for this patient? Then the first line management is lower the BP of this patient. The most important aspect is कि कैसे BP low करेंगे. So इस patient के लिए we will have to maybe do a ventriculostomy, because अगर ये bleed बढ़ता जाएगा, let me just distort the diagram now. आपको बढ़ाने का जरूरत नहीं है. Let me say the bleed is increasing. So the bleed will press on the ventricles also, and when it will squeeze the ventricles, if the bleed is bigger, it will squeeze the ventricles, then it will also cause hydrocephalus. The ventricles will start getting dilated in this patient, and because the pressure in the brain will raise, what I can do is I can put a intracranial pressure monitoring catheter. This is the sensor I was talking about. I can put a intracranial pressure monitoring catheter, and this will ensure, this intracranial pressure monitoring catheter can be then put, and this will ensure that the pressure in the brain will become stabilized, because you will do a ventriculostomy, which is the most effective method to control the pressure in the brain, because the bleed will squeeze the ventricles. So therefore raised ICP is developing. But apart from this, if he says what drug will be given to lower the blood pressure in this patient, then the main drug that I'll be using is a calcium channel blocker by the name of nicardipine, or I might be using labetalol. And he has also asked in NEET PG that what will be the target blood pressure of this patient. I mean, what's the target that we need to achieve? So when I will give nicardipine or labetalol, the target blood pressure I want to achieve is something in the range of about 140. The systolic blood pressure I want to achieve is something in the range of 140, diastolic something in the range of 90. I don't want to go to 120 because if I will decrease to 120 by 80, there would be a brain infarction occurring in a patient. Remember, his BP was like going in excess. Hypertensive crisis ka definition I've discussed in cardiovascular system is systolic more than 180, diastolic more than 120 millimeter of mercury with evidence of target organ damage. This is the target organ damage, guys. The damage in the brain is the target organ damage. So यहाँ पे दो steps करने हैं. First is lower the blood pressure. Second is control the pressure in the brain. Two pressures I'm talking about: raise ICP and blood pressure. To control the raise ICP, I will be putting a intracranial monitoring catheter that is having a sensor at the tip. When the pressure will be more than 20, the sensor will allow the valve to open, the CSF will flow out into a sterile container. So we can also call this as EVD, that is external ventricular drainage or ventriculostomy. This is one of the most effective methods to lower the pressure in the brain that we regularly employ in our patients of raise ICP, especially with intracerebral hemorrhage. Second is control the BP, because otherwise they would be rebleeding. So I will give nicardipine or labetalol, and I will not decrease the blood pressure to 120 by 80, because if I suddenly fall to 120 by 80, I will cause a brain infarction. So the target blood pressure needs to be obtained as something in the range of 140 by 90, not lesser, something in the range of 140 by 90. And this will be presentation of hemorrhagic stroke. So what I've done is describe various types of CNS bleeds before you, but from the medicine perspective, the main ones are either like that are asked as subrectal hemorrhage. Second is the one that I've discussed at this moment, that would be hemorrhagic stroke. Then a couple of stroke syndromes which are taught in anatomy also. So at the moment, because this is a revision part, so I will focus on the words which are important. Weber syndrome is where corticospinal tract gets involved. I'll draw a line diagram, then I'll erase it. आपको diagram बनाने का जरूरत नहीं है. No need of drawing the diagram, because in exam he will expect you to remember the core information. देखो ऐसे जैसे midbrain का representation होता है. This is the Edinger-Westphal nucleus. This is the oculomotor nerve that is traversing. This is like 3 and 3 oculomotor nerve. I am again saying I'll erase the diagram. No need for this. What I want you to appreciate is कि ये वाला जो एरिया मैं अभी ड्रॉ कर रहा हूँ, this is the area of substantia nigra. Substantia nigra is where the dopamine release is to be happening, and this area usually gets involved in Parkinsonism. The anterior area, ये वाला जो area है, this is where the corticospinal pathway is traversing. Corticospinal pathway is the pathway that is like controlling each and every muscles in the body, like the face, arm, and the leg. And now I'm showing a blood vessel. This blood vessel is called as the posterior cerebral artery. It is giving off branches like this. It's giving off branches like this. And let me say, due to atrial fibrillation, there is a clot which is occluding this branch. So if this branch will get occluded, then this entire area will get affected. I mean, we will be having is a ischemic damage of the following area that I'm currently marking before you. This whole area will start getting affected, and because the blood supply of the oculomotor nerve will be affected and corticospinal pathway will be affected, so person will be developing ipsilateral third nerve palsy. By default in Weber syndrome, what happens is that midbrain gets affected. So if midbrain is affected, then it would always be third nerve palsy. There are 3 examples which are present in this line diagram for midbrain stroke: Weber, Nonthangel, and Benedict. And in all 3 of them, by default, it will be a same-sided third nerve palsy. Third nerve palsy is present, but because corticospinal pathway is also present, there would be weakness developing. So Weber means weakness. So there would be a contralateral weakness due to hemiplegia, including the opposite side lower face would be present. So this line diagram basically represents before you Weber syndrome at the moment, where the person would be having damage to the crus cerebri. Crus cerebri is where the corticospinal pathway is present. Now in the same diagram, I will move a little posteriorly. I'm showing a diagram, or I'm showing an anatomical structure जिसका नाम होता है superior cerebellar peduncle. This superior cerebellar peduncle that I've currently shown before you is connected to the opposite side cerebellum. And suppose if this blood vessel gets blocked, like suppose the clots are affecting this particular area, then I'm showing an infarct once again. This time the infarcted area, I'll use a different way to show the infarct. This area got infarcted. तो अगर ये जो मैंने येलो से एरिया दिखाया, दिस गॉट इन्फेक्टेड, तो मैंने दिखाया कि थर्ड नर्व भी गई एंड साइमल्टेनियसली सुपीरियर सेरेबुलर पेडंकल आल्सो गेट्स अफेक्टेड. सो आई विल अगेन हैव अ इप्सिलैटरल, आई विल अगेन बी हैविंग अ इप्सिलैटरल थर्ड नर्व palsy, and because of superior cerebellar peduncle which is connected to the opposite side cerebellum, there would be a development of contralateral ataxia in a patient. So in patients of non-Thangel syndrome, not steady because there is a ataxia that is present in a patient. In Weber syndrome, I said weakness, that is contralateral weakness due to corticospinal pathway involvement. In non-Thangel syndrome, patient is not steady because of ataxia component, because the superior cerebellar peduncle is connected to the opposite side cerebellum. Here, anatomy people will say ipsilateral ataxia. No, guys, it's not ipsilateral. In Harrison, it is categorically mentioned. In non-Thangel, it is a contralateral ataxia. And then is Benedict syndrome. In Benedict syndrome, it is the basal ganglia involvement that happens. So the question will say contralateral tremors, contralateral chorea present in a patient. If you ever get a question of third nerve palsy with basal ganglia features, answer B for basal ganglia, B for Benedict. इतना तो निकाल लोगे ना, tremors, chorea, rigidity, they are all features of basal ganglia damage. So if he says basal ganglia damage, Benedict. If it is not steady, ataxia, that is non-Thangel syndrome, the one marked in yellow. And if you look at the green marking, जो थोड़ा आगे था, जिसको हम बोलते हैं ventral midbrain syndrome, it is Weber syndrome. So all the three, Weber, non-Thangel and Benedict, are examples of midbrain stroke. डायग्राम इज नॉट इंपॉर्टेंट गाइस, क्योंकि एग्जाम में आपको ना डायग्राम याद रहने वाला नहीं है, क्योंकि वहां पे देखो इतना टाइम नहीं होता है कि आप ये सोचोगे कि कौन सा स्ट्रक्चर इन्वॉल्व हुआ और कौन सा नहीं हुआ है। तो इसको आप बनाना चाहो तो बना लो, मेरे हिसाब से तो देखो अल्टीमेटली रिवीजन जब करना है ना, तो यू हैव टू बी वेरी हैविंग वेरी प्रिसाइज नोट्स। तो वी विल प्रैक्टिस दिस अगेन। मिड ब्रेन स्ट्रोक के मैंने 3 एग्जांपल बोले, क्या क्या है, वीबर, फिर उसके बाद में अगला जो था दैट वाज नॉन-थैंगल सिंड्रोम, नॉट स्टडी वाला, एंड देन वाज बेनेडिक्ट। easiest to remember is Benedict. By default midbrain contains the oculomotor nerve, so third nerve palsy तो सभी में ipsilateral है। In Benedict it is the basal ganglia involvement, so they would be contralateral tremors, contralateral rigidity, chorea वाले features दिए हुए होंगे। But अगर वो cerebellar manifestation दे दे, contralateral ataxia, patient is not steady, that is because superior cerebellar peduncle SCP got involved, that is non-Thangel syndrome। और वीबर में वीकनेस थी, कमजोरी थी, स्ट्रोक में तो वीकनेस आती है ना, तो ऑपोजिट साइड की वीक, बाय डिफॉल्ट क्या होता है, हमेशा ऑपोजिट साइड की वीकनेस होती है और सेम साइड की थर्ड नर्व इन्वॉल्व हो जाती है। सो थर्ड नर्व पैल्सी इज बाय डिफॉल्ट प्रेजेंट हियर, एंड देन इज वीकनेस, नॉट स्टेडी, एंड बेसल गैंग्लिया इन्वॉल्वमेंट्स फॉर मिडब्रेन स्ट्रोक। नेक्स्ट अप इज द टॉपिक ऑफ Millard-Gubler and Fovil syndrome. Both of them occur due to damage to the pons. So pontine stroke will be having manifestations of 2 cranial nerves getting involved simultaneously. That is why it is of interest to the examiner. In the superior data where midbrain was getting involved, it was only 1 cranial nerve, that is the third nerve. Now he will say ipsilateral 6th nerve palsy. Along with that, he will also say that there is a ipsilateral 7th nerve palsy happening. 7th nerve happens to be motor to the face. Sensory to the face is the 5th, motor to the face is the 7th nerve. So patient would be having like paralysis of one half of the face, and then there would be a contralateral hemiplegia. The highlight of always whenever the brainstem gets involved, whether it is midbrain, whether it is pons, or whether it is medulla, you will always have crossed manifestation. So that again is a very good hint in a question, that if he begins by saying in the physical examination findings that crossed hemiplegia is present or crossed findings are present, that indirectly tells you that the patient is having a brainstem stroke. Now, because both Millard-Gubler is having 6th and 7th nerve palsy and Fovil also is having 6th and 7th nerve palsy, what is the fundamental difference? And this difference was the one that was asked in NEET PG. You see, in Fovil syndrome, it is the nucleus of the 6th nerve that also gets involved, and the issue is that the 6th nerve nucleus is not involved in Millard-Gubler syndrome. Now, what is the difference that is created because of that? You see, the 6th nerve nucleus communicates with the 3rd nerve nucleus or the opposite side. Like for example, if I request you, doctor, please look to your left side, then your left eye lateral rectus will be working and your right eye medial rectus will be working, so that you can have a conjugate horizontal gaze. What I'm saying is the 6th nerve nucleus is communicating directly with the 3rd nerve nucleus, so that we can have a horizontal conjugate gaze. And because the 6th nerve nucleus is damaged, therefore the communication with the opposite eye 3rd nerve nucleus will also be lost, and therefore this gaze palsy as a manifestation would be occurring. So here the MCQ will say the word lateral gaze palsy. In contrast, now check out Millard-Gubler syndrome. There, what is the word that I have written? It is lateral gaze weakness. You can notice the subtle difference that is present in the MCQ. Both MCQs of Millard-Gubler and Fovil syndrome, the common findings that will be given in the question will be, I'll highlight the common findings. Common finding will be 7th nerve palsy will be there, contralateral hemiplegia will be there. But for the 6th nerve palsy, there is that subtle difference that I said, that the nucleus of the 6th nerve is involved only in Fovil syndrome. So it will say the word lateral gaze palsy. Whereas when it comes to a question of Millard-Gobler syndrome, because the nucleus is not involved and only the sixth nerve is involved, so the word will say, or the MCQ will say, lateral gaze weakness. So very closely worded questions, I can say like this, that Millard-Gobler and Foville, why they are asked in by the examiner is because of high probability that somebody can mess up with the data. I'll just move the slide once again like I did in superiorly for midbrain stroke 3 varieties, so that we can just remember the facts. You see, I told you Foville and Millard-Gobler. Let's do it under 30 seconds. What you're supposed to remember is Foville syndrome, where sixth nerve nucleus is involved. Communication with the opposite side, third nerve nucleus is also gone. So conjugate gaze palsy with seventh nerve involvement, that is facial paralysis and contralateral hemiplegia would be occurring. In contrast, if I say the word lateral gaze weakness, not palsy, along with seventh nerve palsy and contralateral hemiplegia, it becomes Millard-Gobler. So they will teach you various things like 3 alphabet, like remember Millard-Gobler is 7 alphabets. I don't think so that you need to get it into such so much of primitive stuff. Like if you just get hang of these terminologies that I have mentioned on this slide, you are sorted as far as the topic of brainstem stroke is concerned. The top three are involvements of the involvements of the midbrain, and the blood vessel that is involved in all the top three involvements is called the posterior cerebral artery. Whereas when it comes to the involvement of the pons, then it is the basilar artery. I'll write this also, but like I said, it is PCA, then is the basilar artery. And then if I go down, that is when it involves the medulla, then the manifestations are even more characteristic. Like this area that is currently shaded is the medial part of the medulla, and here what is involved is the 12th nerve nucleus, and along with that the corticospinal pathway is also getting involved. So the manifestation is unmistakable. Medial medullary syndrome. This is famous because they will always ask you regarding the tongue deviation, and you know it even from your anatomy classes that in medial medullary syndrome it will be the tongue deviation to the same side. What is the nerve that would be, what is the blood vessel that gets occluded here? Your answer is the anterior spinal artery. Before I write anything, I want to remind you that if they give you image of the tongue of the patient, no, either it will be one question on tongue fasciculations. The tongue fasciculations is always described for motor neuron disease or amyotrophic lateral sclerosis. The second time they show you an image of the tongue and the tongue is deviated to one side, by default it becomes a question of medial medullary syndrome. It would be ipsilateral 12th nerve palsy and a contralateral hemiplegia. I have already explained to you that whenever brainstem is involved, it will always be same sided cranial palsy. हेमीप्लीजिया तो देखो बाय डिफॉल्ट होता ही ऑपोजिट साइड पे है ना, बट इन दिस पर्टिकुलर केस इट इज लाइक द सेम साइडेड कर्नल पैल्सी दैट यू नीड टू रिमेंबर. And the question said doctor has asked the patient to protrude his tongue out of the mouth. Then you are noticing that there is a ipsilateral tongue deviation that is happening along with contralateral hemiplegia. Now we will contrast this with lateral medullary syndrome, which is overall, I would say, the most frequently asked one among all these brainstem strokes. In lateral medullary syndrome, the alternative name is Wallenberg syndrome, and the artery that gets involved in this particular case is the vertebral artery. There's a branch of the vertebral artery also that needs to be taken care of, that is pica. But if both are given in MCQs, first answer would be a vertebral artery involvement, second would be a pica, that is posterior inferior cerebellar artery involvement occurring. And here, like 12th nerve will not be involved. So like one question was ultra simple. He said what nerve is not involved here? Then the 12th nerve originates medially, so it does not get involved, and rather the 5th, 8th, 9th, 10th are the ones that are getting involved. Now, because of the involvement of the 5th nerve, what will happen is that one side of the face, all sensations would be gone. Like this representation or the shading that I'm showing, I'm saying whether it is hot, cold, tactile localization, tactile discrimination, you name it, all kind of sensations on one side of the face would be affected in the patient. This is manifestation of the 5th nerve involvement, which is sensory to the face. The lateral spinothalamic pathway, which also gets involved here, is actually carrying sensations, that is two of them, but it is carrying these sensations from the opposite side of the body. So what will happen in this patient is that the pain and temperature sensation would also be affected, but in the opposite side. So I'm just putting it in dotted fashion to say that on the opposite side of the body, all sensations are not getting lost. Only it is the pain and the thermal sensation that is getting affected. All other sensations like tactile localization, discrimination, proprioception, like all those vibration sense, they are the ones that would be preserved here, but pain and temperature would be lost. Then due to the involvement of the 8th nerve, you could be having like vestibular symptoms. They could be vertigo, which could be associated with very severe nausea. And because of the involvement of the 9th and the 10th nerves in these patients, the bad news would be that important reflexes would be lost. Like for example, the gag reflex would be affected, and then the cuff reflex would be affected. So I can say that if by mistake the family member of these patients makes them drink water, then there is a high risk of aspiration developing in this patient. And because like the 10th nerve is more involved, so even the change in the voice can be present, because soft palate will also not be able to work, and vocal cords will also be paralyzed. So if vocal cords are affected, then there can be development of dysarthria slash anarthria in a patient, meaning the word dysarthria would be unclear speech. You see, when I talk about Broca's area damage, or when I talk about Wernicke's area damage, then the word I'll be using is aphasia. But here I'm using the word unclear speech, because vocal cords are going to be powered by the vagus nerve, and because sympathetic tract gets affected, so he will also talk about Horner syndrome. So there will be so many manifestations that it will be impossible for you to forget this manifestation of lateral medullary syndrome. The numbers to be remembered are 5, 8, 9, 10, and is not involved in this condition is the 12th nerve. And the easiest way to remember this is what I said. On one side of the face, all sensations are gone. On opposite side of the body, two sensations are gone. That is pain and temperature. I'm just drawing a cross once again to say that on one side of the face, no problem, and the opposite same. When I've drawn a cross like this, what I'm trying to say is one side of the face, whichever side blood vessel is affected, like right vertebral artery is one, so right side of the face, and left side, pain and temperature would be lost in a patient. This is usually the starting point as well as the end point of the question. The technical word used here would be crossed hemianesthesia. We do not read this terminology anywhere else, guys. This is one of the one of the main reasons why this topic is being discussed, that is crossed hemianesthesia is a feature of, like, either the starting point of the question will be this or the end point. What I mean by starting point is question will say crossed hemianesthesia seen due to, answer is lateral medullary syndrome. Vice versa, he will say patient presented with crossed hemianesthesia, which is the blood vessel that would be involved here. The answer would be given as vertebral artery. So very classical manifestations have been described at this moment. And if I just move up the slide, I want to say that the top three manifestations that occurred, like there I did not mention the blood vessel initially, but I'm adding here that it is the posterior cerebral artery and its branches that would get affected. So midbrain stroke would be affected. When it comes to Millard-Gubler and Fowell syndrome in a patient, what are the blood vessels that get affected? That is the basilar artery. If you mentally visualize like this, first is the midbrain, then is the pons, and then is the medulla. In the midbrain, it is the posterior cerebral artery. In the pons, it is the basilar artery, and in the medulla, it is the vertebral artery. And then there's a medial branch related to the vertebral artery that is called as anterior spinal artery, which gets involved here. And if I move down lateral medullary syndrome, there's a lateral branch that can get involved, that is pica. But most books mention for lateral medullary syndrome, also called as Wallenberg syndrome, first involved is the vertebral artery. Next, we talk about what are the speech implications that would be happening. At this moment, I'll say like this: most of us are right-handed people, so the dominant part of the brain is left. So I am currently talking about what happens in a person if the left middle cerebral artery will get affected. Left middle cerebral artery can be drawn like this. This is having a superior branch of the left middle cerebral artery supplying the Broca's area, and then I'm showing an inferior branch that is supplying the Wernicke's area, and this is the main trunk of the left middle cerebral artery that has currently been shown. Now, what you need to understand is that Broca's area is responsible for certain functions. One of the functions that you know from your basic sciences classes is it is responsible for expression of speech. Like at the moment when I'm talking in front of you, it is like speech expression that is regulated by the Broca's area. Apart from the expression perspective, it is also responsible for fluency. And third is like syntax. Syntax means grammar. Like I can switch between English, Hindi. I can switch between past tense, present tense. So that ability of our brains to switch from like language to language, past tense, present tense, future. Like I say, patient came yesterday. Day before yesterday he had like weakness in his left arm, and today we have like done this intervention in this patient. So like past tense, present tense is all like syntax or grammar. Whereas when it comes to Wernicke's area is mainly responsible for comprehension, that is for understanding. Like if I say to you, okay doctor, have you understood what I'm saying? So you say, okay sir, I've understood it, that's because of the Wernicke's area. And then I'm showing a pathway. I'll draw it a little thicker, that is connecting the Wernicke's area with the Broca's area. This structure that I've shown in red is again itself a question that you'll be able to relate very well. In this particular, let me first give the name here. The name is arcuus fasciculus. Arcus fasciculus is that anatomical pathway which connects the Wernicke's area and the Broca's area. And the function of this Arcus fasciculus is repetition. Like lots of time in a class or in a live class, I say, okay, if you have understood it, guys, please repeat after me. So if you can understand and then repeat after me, that is a function related to Arcus fasciculus. Like this was an FMG exam question. He said the patient can understand all the facts that you can say, but he cannot repeat. He said, what is the area of the brain involved? Then answer would be arcuous fasciculus is the one that is getting affected, because of which the speech part of the patient is getting affected. The repetition of the patient is getting affected. I repeat that again. The question said patient can understand everything. So that means Wernicke's area is okay, but the repetition is not a possibility. So that means arcuous fasciculus is the one that is getting affected. And now let's put in the data here for like the word motor aphasia. When I say the word motor aphasia, what that means is that the blood supply of the Broca's area is gone, and therefore all these functions would be lost in a patient. So motor aphasia will occur only if Broca's area is gone. That means superior division of the left middle cerebral artery will get affected. So because they want to hear about the vascular territory, here you will say that motor aphasia implies blood supply of the Broca's area is getting affected. So superior division of the left middle cerebral artery. Dominant area of the brain is related to speech. Right-handed people, dominant part of the brain is left. Already explained to you. So superior division of the left middle cerebral artery occlusion results in motor aphasia in a patient. Let us now look at like what will happen in the patient. So all these functions would be lost. Expression, fluency, syntax. So sometimes instead of writing the word motor aphasia, he may even write the word non-fluent aphasia. The word is non-fluent because fluency is a function of the Broca's area and it is getting lost. Let's do this again. Suppose in a patient, unfortunately, there was a clot that started from the left atrial appendage in atrial fibrillation, and unfortunately, the clot went and occluded the inferior division of the left middle cerebral artery. Then the blood supply of the Wernicke's area will get affected. If the blood supply of the Wernicke's area will get affected, then the comprehension part will be affected in a patient. So receptive dysphasia basically means Wernicke's area damage, and in this case, like we will say, it is the inferior division of the left middle cerebral artery that can, you see, I cannot predict like which way the clot will go. It could be one, it could be multiple. Let me say the clot today decided to go down into the left MC inferior division, then the receptive dysphasia, that is the Wernicke's area, will get affected. I'm writing B here to mean that Broca's area is getting affected. I'm writing W here to mean Wernicke's is for reception, understanding, motor expression. When you speak out, like you speak out is Broca's area. It's like the motor area related to speech. So B means that it is the Broca's area that is getting affected. W means it's the Wernicke's area that is getting affected. And now I can also say the fact that patient can speak fluently. If Wernicke's area is damaged, Broca's is not affected now. If Broca's is not affected, whatever will come to the mind of this guy, he will continue speaking. So therefore, the word written will be a fluent dysphasia. The bottom line is that he's not answering your question. Like you asked him to repeat a particular task or you asked him to do a particular task. The guy is not following your commands. Like you asked him, repeat after me 1, 2, 3, 4, 5, 6. Whatever you will say, he will not do that. Anything under the sun, whatever words that come to his mind, he might be saying. Like he's saying words like dog, chicken, Pakistan. Dog is like an animal, chicken is a bird, and then Pakistan is a country. In his mind, it's just a mishmash of words. So therefore, in this patient, I can say the word jargon speech. Jargon speech is basically like a mix mash of speech of words, randomly spoken words in a patient. Or the question might begin by saying the word salad. Like in salad, we eat cucumber and tomatoes and onion. So he's randomly saying some words which are like not interrelated to each other. So any of these terminologies could be written in a question. How the questions would be framed? Question will say word salad occurs due to involvement of, your answer is inferior division of the left middle cerebral artery, and the manifestation is called as receptive dysphasia. Whether I say fluent dysphasia, jargon speech, word salad, they all mean the same. If he says the word non-fluent, then immediately you know it is motor, that is the Broca's area that is getting affected. Now comes the word anomic aphasia. Meaning of the word anomic aphasia is difficulty in naming object. Like for example, if I show you a cell phone, then immediately you can tell now, like cell phone is a very common article now in India. So you will show a very common article to the patient and you will notice that he knows it is a cell phone. Cell phone is not something big deal, right? But he will take some time in being able to say it. And even when he's saying, he's not saying mobile phone or cell phone, like L4, like some random words are coming out. He knows it's a phone, but like it's taking time because the neurons are confused. This can be due to uremic encephalopathy. It can be due to hepatic encephalopathy. Earlier, when I was describing, uremic or metabolic encephalopathy or hepatic encephalopathy to you, I was describing the word asterixis. Now mentioning one more feature with A for metabolic encephalopathy, that is anomic aphasia. At this moment, I expect you to remember whenever you read the word metabolic encephalopathy, it means hepatic encephalopathy, uremic encephalopathy, carbon dioxide narcosis, and two features with A are present here, that is asterixis and anomic aphasia. Now, the worst case scenario. The worst case scenario is, I'll zoom in. Suppose there is a clot that is causing occlusion of the main trunk of the left middle cerebral artery. Like there's a big clot, it is causing occlusion of the main trunk. Then you can see the main trunk is gone, then the whole system will shut down. Superior division, inferior division, all the blood supply is getting affected. So God forbid if in somebody the left MCA gets involved, then the whole system shuts down, and that is what we commonly get in our patients for stroke. That is in all the examples that I've given. Global aphasia. Global aphasia is due to occlusion of the left middle cerebral artery trunk that gets involved in a patient. Earlier I was saying the branches, that is the superior or the inferior division, but now I described left MCA territory getting involved in a patient, that is global aphasia, which is one of the common manifestations that is seen when the dominant parietal lobe of the patient slash left MCA gets occluded. Next up is the topic of transient ischemic attack. This is also called as mini stroke. Like I'm showing, the patient's brain blood vessel is having a clot getting formed. So there is interruption of the blood supply of the brain, and interruption will produce neurological symptoms. But once there is a thrombus that is getting formed, then there is activation of the anti-clotting system of our body. The anti-clotting system operates on plasmin. So what will happen is that now the clot will start getting disintegrated. And when the clot will get disintegrated, as you can see in this representation, when the clot is getting disintegrated, there is restoration of blood supply forwards, and due to restoration of blood supply, the neurological symptoms will disappear. Students are like, what sir, you said symptoms will come and then disappear by themselves. Yes man, transient ischemic attack is a warning symptom for stroke. It's a mini symptom for stroke, where initially you get neurological symptoms and then they resolve by themselves thanks to the activity of plasmin, which is like the anti-clotting system in the body. Let's take an example here. This particular individual is having atherosclerotic risk factors like diabetes, hypertension, cigarette smoking, obesity, standard risk factors. This guy is watching television. He's watching that America has attacked another country in the world, right? They attacked Venezuela, then they attacked Iran. So like America has attacked another country in the world. And this guy, he's a retired person. He's watching television news. He says, doctor, suddenly I felt there was a black curtain falling in front of my eye. And he says, I went blind in one eye. I was like, what, sir? You went blind in one eye? He says, yes, sir. There was a curtain in front of my one eye. I could not see anything for maybe 5 minutes, 10 minutes. And then by the grace of God, my vision came back. I told him, are you kidding me, doctor? Are you kidding me, man? I mean, you tell me that you went blind in one eye. In fact, sometimes there could be clots developing in both the ophthalmic arteries. So there is another patient who had come. He told me, sir, I was watching television and suddenly everything went black. It was as if there were two black curtains in front of my eye. I could not see anything. I said, then what happened? He says, after 10 minutes, my vision came back. I was like, are you kidding me? No, you don't have anybody to talk funny in front, like you choosing me to act funny. Like you tell me you went blank, and you went black in both your eyes. I mean, you could not see anything, and then everything came back normal. I asked him, did you become unconscious? I thought he might have had a syncopal episode, like vasovagal syncope. So I thought, did you fall back unconscious? He says, no, sir. His wife is also saying, no, sir, he did not become unconscious. He could sit up, everything was okay, hands, feet, he could move everything, but like he was saying that, oh my god, I just can't see with my eyes. And after a few minutes, there is restoration of vision in this patient. This line diagram that I described before you is to explain that there would be a transient loss of vision. There would be a transient loss of vision, like the reds that are shown, that is like everything went black, and then the vision of this patient is coming back to normal. This presentation that I made before you, just for explaining purposes, in the MCQ language is called as hemaurosis fugax. The meaning of this word is that there is a transient onset blindness that had occurred in this patient, unfortunately, because there was a clot formation in the one of the branches of the internal carotid artery, ophthalmic artery. Let's do this again. Same patient tells me, sir, last month also I had a problem. I said, what problem did you have? He says, sir, last month I was like on a weekend, I was shaving in the morning. So he's like shaving in the morning. He says, suddenly the shaving razor fell from my hand. I said, what's the big deal? No, your shaving razor can fall from your hand in the wash basin. What is the big deal? He says, sir, when the shaving razor fell from my hand, I tried to like pick it up with my right hand. My right hand suddenly became paralyzed. He says, sir, my right hand became paralyzed. I could not move it. I could move my left arm. I could stand. I could move my trunk. I could do everything. But when I looked myself in the mirror, I had weakness. Like there was like, sagging of the muscles of one side of the face. There was like sagging weakness of one side of the face. So this gentleman is telling me that he had an event like this earlier also. Like whichever side middle cerebral artery will get involved, on the opposite side, the person would have developed a face asymmetry or a face weakness as well as a arm weakness. He said these symptoms of face weakness and arm weakness persisted for like maybe 1 hour, 2 hour, whatever, and then like the symptoms resolved by themselves. And he says, I neglected going to a doctor, but like because another event has happened today, like I could not see, so I'm very scared, sir, please treat me. Let me do it again. Anterior cerebral artery supplies the area of that our brain that controls our legs. So I have a patient who says that I was sitting watching television news and suddenly I felt as if there is no power in my right leg. So being a non-medico, he thought some nerve got compressed. So he says, sir, I thought that maybe I'm sitting in some wrong position, so some nerve got compressed. I could not move my right leg. He says my right leg became paralyzed for 15 minutes, 30 minutes, maybe 1 hour, and then gradually the power came back. So I neglected it. In some patients, the blood supply, like related to both the legs, would be affected. So he says, I thought I might become wheelchair bound, but by the grace of God, the power in my legs came back. Similarly, if vertebral artery gets involved, then vertebral artery supplies the brainstem, then cranial nerve number 9, 10 can be involved. So what can happen in this patient is, he says, this is a retired person. He says, I was drinking water and water is coming out of my nose. Like I can say that if at any point of time, it might have happened that you're drinking water, your brother or sister made you laugh and water start coming out of your nose. So nasal regurgitation of fluids is a feature that you always encounter with like vertebral artery involvement. That's the word. Nasal regurgitation of fluids is always seen with vertebral artery involvement. And additional point which I want to say is there might be nasal twang to the voice. Like his grandson is making fun of this man that see how Dadaji's voice has changed. There's a nasal twang because vertebral artery got affected. So they can be nasal regurgitation of fluids. They can be a nasal twang to the voice of a patient, or I can say the patient may not be able to speak at all because the blood supply of the vocal cords got affected. So there was a dysarthria or an anarthria occurring, but then gradually the voice came back to normal. Guys, all these things I'm not saying that should be occurring in a patient. If any one of these features will develop in a person, if any one of these manifestations will develop in a person and then it resolves by itself within 24 hours as an upper limit, we call it a transient ischemic attack. I'll write it here. If any one of the neurological symptoms that I've written from point number 1 to point number 4, you don't need all of them. If any one symptom or symptoms, I can say, is occurring in a patient, and after that there is a development of spontaneous improvement or spontaneous resolution, that is when we say the word transient ischemic attack. The word TIA is self-explanatory, that there would be spontaneous resolution of symptoms thanks to the power of plasmin, which is like the anti-clotting system in our body, which will disintegrate the clot. The cutoff within which the resolution should occur is approximately 24 hours. Though in majority of cases, guys, if it's a TIA, in a majority of cases, improvement will begin by the first hour itself. See, if it is stroke, then there can never be an improvement. Stroke always has a bad prognosis. You will never ever have an improvement. But in transient ischemic attack, there can be a spontaneous resolution within 24 hours. So the message is, definition of transient ischemic attack is any one of the neurological symptoms that I described below before you, if they come and they disappear by themselves within an upper limit of 24 hours. Here also don't be under an impression that 24 hours is some Lakshman Rekha which cannot be crossed. Sometimes it may take 26 and sometimes 28 hours also. Like there was an FMG exam question in which question said that patient symptom improved in 36 hours. And a lot of doctors were like, no, sir, it can't be like this would be stroke, sir, because it was 36 hours. Why? I can say that majority improvement is occurring by 24 hours. I mean, it can take 22 hours also, lesser. It can take 26 hours also. So the point is, this is an artificial cutoff. If the symptoms are improving after, let me say, somebody had neurological symptoms and it improved after 10 days, 20 days, 30 days, whatever, then I will agree. If it is days and like weeks and months return and improvement in the hand power is occurring, I agree it could be stroke, and with physiotherapy improvement can occur. But if it is matter of few hours now, then you don't answer like stroke, then you will say it is a transient ischemic attack in a patient. And therefore now we have an online calculator available which is called as ABCD2 score. This ABCD2 score, which you can see on the slide, is basically used to predict the percentage of chances of stroke. This I've said earlier also, I'm saying it once again. This is not for diagnosis of stroke, it is not for diagnosis of a TIA. It is to predict whatever percentage chances. It could be 20%, it could be 10%, it could be 5%, it could be 0% based on the statistical score. So the parameters are age, blood pressure. You will notice that here age is coming only once, unlike in CHAD S2 VSE score, age was coming twice. Remember, CHAD S2 VSE score is to decide the need of anticoagulation in atrial fibrillation. Here age is coming only once, blood pressure more than 141 NT is 1 point. Clinical features, it is unilateral weakness which is given 2 points. Duration more than 60 minutes is given 2 points. So take a mental note of what are the features where 2 points are present, and you have to put in the statistical, like in the software, like symptoms lasted for 10 minutes, maybe 20 minutes, maybe 60 minutes. Let me put a question to you. Suppose you have patient A in whom spontaneous resolution occurred in 20 minutes. There's a patient B who had spontaneous resolution in 80 minutes. Who will have higher chances of stroke? The guy with B, if it will take longer time for symptoms to resolve, so next time he may not be so lucky and the guy can develop a stroke in future. So depending on this is statistical score value. Diabetes is also D2 is because D is for duration as well as for diabetes. Remember the full form: age, blood pressure, clinical manifestations, duration, and then diabetes mellitus present or not. If these parameters are present in a person and we calculate a score, then we can predict whether it's 20%, whether it's 10% chances of stroke occurrence in a patient, and then we will do workup. In the workup, the first investigation we will do in this guy is echocardiography. When I'll do echocardiography, son is saying, come on, sir, you are saying my father will have features of stroke. He's having neurological features also. No? Neurological features are like face weakness, arm weakness. So you are not doing CT scan. You're not doing CT scan, you're doing an echo. So I'll explain to him, smart boy, I'm doing an echo because actually the clots that went in the brain came from the heart. No. So we will not do a CT scan, we will do a echocardiography to find the etiology, that is mostly atrial fibrillation sending clots up into the brain. The second test I will do is ECG, again because I want to detect atrial fibrillation. Suppose echo and ECG is normal, then the third test I will do is carotid artery Doppler. Why am I doing a Doppler? Because somebody could be having atherosclerosis of the carotid artery. So the clots could be going from the carotid artery up into the brain of the patient. Clots could be going up from the carotid artery into the brain of the patient. So carotid artery Doppler. Then is lipid profile because atherosclerosis would be present. So echo, ECG, Doppler, lipid profile. They are like some of the very classical things that you need to remember for the workup of any patient of TIA, that is a transient ischemic attack. We don't do a CT scan in a TIA patient. We do CT scan in a stroke patient when neurological symptoms are well developed. But here the symptoms are transient. They occur for like few seconds to few minutes and then they disappear. And in majority of cases, improvement starts happening by the first hour itself. Total improvement will occur by 24 hours, but if it is a TIA, improvement usually occurs by the first hour itself. Now, in the workup of these patients, we will be starting the patient on low dose aspirin. We have to start the patient on 75 milligram anti-coated aspirin, and along with this, we will also be giving ticagrelor. He says you should be giving 2 antiplatelet drugs in this patient because the risk of stroke is very, very high. So therefore, for management of this condition, first line we go for DAPT, that is dual antiplatelet therapy. I will also be starting atorvastatin in this patient because lipid profile in most Indians would be deranged and atherosclerosis is an independent risk factor for this problem. Along with this, an additional medicine that I might be starting is a directly acting oral anti-clotting drugs. This DOACs would be started only in those patients where there is demonstration of clots in the left atrial appendage. Like this, I'm writing plus minus to say that this medicine will not be given in all the patients. Only if the patient is having demonstration of clots in the left atrial appendage, that I will be starting the patient on apixaban, which is a directly acting oral anti-clotting drug. If I don't have apixaban, I can give warfarin in the patient also, but I've written plus minus because not all patients will be demonstrated to have clots in the left atrial appendage. So two medicines that must always be given are beginning with A, aspirin and atorvastatin, and if required, the third A can be added. So there are 3 A's that are being used for management of this patient: aspirin along with ticagrelor, then is atorvastatin, which is like a very good drug that decreases the levels of bad cholesterol LDL, which are causing atherosclerotic buildup in the internal carotid artery or middle cerebral artery. And then is apixaban. So these are some of very, I would say, classical discussions that have had hardcore neurology aspects that I've described for ischemic stroke, hemorrhagic stroke, and then a transient ischemic attack, which is a warning symptom. This has excellent prognosis. I mean, I can put a smile on my face saying TIA, I'll be able to manage. Stroke, I'm little, dicey because recovery will be bad. So patients' letters are never happy. Next up is the topic of myasthenia gravis, which affects the neuromuscular junction. If I draw a crude diagram, I can say like we can take this as a representation of a nerve, and at the terminal end of every nerve, there is presence of calcium channels. So whenever we stimulate any nerve, then the calcium channels will open, and this will facilitate the release of acetylcholine. So these small dots that I've shown, we can take this to be representation of acetylcholine, which is which is being released. And this acetylcholine would be like billions of molecules. I've just shown like, let me say 6-7 dots here. So one could be for 1 billion. So let me say 6 to 7 billion molecules of acetylcholine are getting released. Now this will go and act on the receptor, and thereby like the receptor would be stimulated on the muscle end plate, and therefore you would be having is a contraction. I repeat this again, very basic physiology. I said at the distal end of every nerve, there is presence of calcium channels. Whenever we stimulate any nerve, the calcium channels will open, and this will facilitate the release of acetylcholine at the neuromuscular junction, and that results in stimulation, and ultimately like the neuromuscular junction stimulation causes the receptors to be activated, and because of this ultimately like the muscle will begin to contract. Now what I'm saying is that in this condition, there can be autoantibodies that are produced, and these autoantibodies will be the troublemaker. Like the antibodies in this case are attacking these receptors, and thereby like acetylcholine will not be able to act. So the problem in myasthenia gravis is a post-junctional defect where there is autoantibodies that cause trouble, and the name of this autoantibody is anti-acetylcholine receptor antibody. This is the main antibody which is found in myasthenia gravis. Question for you guys, if you read this topic, myasthenia gravis, can you tell me any antibody apart from the one that I have currently told you for myasthenia gravis? One is anti-acetylcholine receptor antibody. Another antibody that you come across? Yes, it is called as anti-MuSK. MuSK would stand for muscle specific kinase antibody. MuSK is anti-muscle specific kinase antibody, which is present here. So myasthenia gravis has multiple antibodies present. The main antibody is anti-acetylcholine receptor antibody. And the question in your paper began by saying, what is the cause for development of myasthenia gravis? You'll be aware Amitabh Bachchan also has myasthenia gravis. In between his career, when he had myasthenia gravis, he had change of his voice, he had like ptosis coming, so he was not able to do proper dialogue delivery. So his dialogue director told him, buddy, you need to see a doctor. And once he started taking treatment, then suddenly his movies became a hit. Amitabh Bachchan has a very good baritone voice. Lot of government announcements are always made in Amitabh Bachchan's voice. I mean, he's the highest individual taxpayer in India for so many consecutive years. I mean, he shoots for KBC, he shoots for movies, whatever. I mean, at 85 years of age, man, or 85 plus years of age, I mean, the guy is a legend in a sense that in spite of suffering from a neurological illness, he's able to perform. So what I want to bring to your attention is that this disease will usually like not cause mortality, but it will cause morbidity in a person. And the question was, why is this patient having this problem? I mean, calcium channels are opening, acetylcholine is released, receptors are getting blocked by autoantibodies. The question is, why is this patient having this problem? So you will say that 65% patients of myasthenia gravis will be having problem with the thymus gland in the form of thymic hyperplasia. This thymic hyperplasia is the source of autoantibodies which are damaging self-neuromuscular junction. So this would be an example of type 2 hypersensitivity. 10% cases of myasthenia gravis could be having a thymoma in which the autoantibodies would then be contributing to damage to the neuromuscular junction. And also remember from the pathology perspective that the myoid cells of the thymus, they act as autoantigen. The myoid cells of the thymus, they act as autoantigen. I mean, the chemical structure of these or the chemical signature of these cells will be identical to that of the receptors of the neuromuscular junction. Antibodies respond to chemical signature now. So the chemical signature of The neuromuscular junction and the myoid cells of the thymus has been found to be identical in these patients, and that is why the antibodies which are present here tend to cross react or self react. I can say auto reactivity is happening here. Autoimmunity is about auto reactivity only, and myasthenia gravis is an example of type 2 hypersensitivity reaction. Please don't get me in that controversy that madam has told type 5 hypersensitivity. I agree, in newer books they might write type 5, but traditional data is type 2 hypersensitivity. If in MCQ, I'm saying it again, if in MCQ 2 and 5 both are given, then answer is 5, no problems. But most MCQs mention 1, 2, 3, 4 only, na, then the answer is type 2 hypersensitivity. And what is happening here is because acetylcholine is present still, the synaptic transmission at the myoneural junction is decreased. I mean, the first thing that they will ask you in myasthenia gravis is what is the fundamental problem? They will not include the word post-synaptic or pre-synaptic because that becomes easy for you. So he will say decreased synaptic transmission at the myoneural junction, and because it's an autoimmune disorder like lupus, no, lupus in the SLE is an autoimmune disorder, so waxing and waning course, remission कभी ठीक नहीं होता, मतलब ये है कि for few years symptoms would be very very minimal and then suddenly the symptoms will tend to increase in a patient. The antibody in this condition, what does it do? It causes blockage of the active site, it causes activated turnover of the receptor and dynamics to the postsynaptic membrane. I mean, whatever I said in simple language by saying antibodies are blocking the receptor's active site, apart from this, they also cause activated turnover of the receptor. If the turnover of the receptors is more, total number of receptors available is less. And there is a physical, like proper damage to the postsynaptic. I said postsynaptic, that's easy, no? Post-junctional postsynaptic muscle membrane is damaged here. So these are like the, I would say, pathology related details for this condition. And the most important aspect is why is myasthenia gravis happening? Then this is due to thymus abnormality. Now let us look at the clinical manifestations that will develop, and the highlight of this condition or neurological disorder would be that there would be a diurnal variation of symptoms. What I mean by diurnal variation of symptoms is that the symptoms will be minimal in the morning, but by evening hours there would be a substantial neurological deficit. Like for example, when this patient of myasthenia gravis will wake up in the morning, then we will not have any ptosis. Like upper 2 millimeter of the cornea is covered by the upper eyelid in all of us. So even in this patient, like the upper 2 millimeter of the cornea is covered by the upper eyelid, and this is like the eyes of the patient in the morning. But by 3 o'clock or 4 o'clock in the afternoon, the patient's eyes are literally half shut. Like the family members of this patient, or let me say the colleague of this lady, is asking her that, are you sleepy? Do you feel like sleeping? That her eyes are literally, half shut like I'm doing at the moment. So she says, no, I'm not sleepy, but I don't know, I feel as if somebody is sitting on my eyelid, somebody is forcibly closing my eyelid. My eyelids are like without her control. Her eyelids are having droopiness. That droopiness is because of like the antibodies affecting these muscles. See, our upper eyelid muscles are very strong. The number of times we blink in the morning, number of times we blink in the afternoon, number of times we blink in the evening is same now. But here you will notice that eyes are literally shut. That's primarily because of the antibodies affecting the neuromuscular junction and causing that post-junctional defect that I was describing. But the peculiarity or the highlight of this disorder is that neurological symptoms are not present in morning. The neurological symptoms are mainly predominant in the late afternoon hours and in the evening. So diurnal variation of symptoms is what the examiner wants to hear for this particular topic, or he will mention in the data or in the data points in the question. Lots of time like ptosis will be given in morning hours also. Now, how is it possible that ptosis will come in the morning hours? Because like a lot of students say, sir, you told ptosis will come in evening hour, then how is it possible in the morning? Let us assume this lady is doing work from home and she's an IT engineer. She works in some big Silicon Valley company. So she's working on the laptop. Now, when she will use her eye muscles in the morning, then ptosis can come in the morning hours all itself. I'm saying that if a person is using eye muscles, like, working on a laptop, playing a video game, or even scrolling through mobile phone, like lots of us have a habit in the morning, first thing we do is pick up our phone, we scroll through the social media. So I can say that when a person is like using a smartphone, using a mobile phone, scrolling through the social media, then eye muscles would still be used, and that can cause development of ptosis. So traditional data is that ptosis in this condition develops in the evening hours, but it can occur in morning also when there is use of eye muscles, like working on a laptop, playing a video game, scrolling through social media on a mobile phone. So the symptom that will occur in the patient will be development of diplopia. If he says what is the symptom, then the answer would be given as diplopia. But if he says what is the finding, If the question says finding, that means examination finding. The meaning of the word finding is examination. Examination finding will be ptosis, and I want you to appreciate that the ptosis in this patient will be asymmetrical. I highlight this fact. In myasthenia gravis, we never have is a symmetrical ptosis. We always have a asymmetrical ptosis. That is the reason why there is a diplopia, because vision formed by, if there is asymmetrical ptosis, the image of the left and the right eye will not be identical, and that is why double vision is coming. Then this person will say that when I drink water fast, you and me can drink water fast, juice for, like in morning, if you and me are late for office, clinic, hospital, we can drink a glass of milk fast. This patient cannot drink anything fast. There would be nasal regurgitation of fluids developing in this patient. There would be dysphagia, there would be dysarthria, because vocal cords will get tired. Amitabh Bachchan's case, he had a perfect dialogue delivery, and then his dialogue delivery started faltering. That is why in between his movies also flopped in a bit. Then he had to do dub. Somebody else was doing dubbing for him. No, so when he took medication, everything is back to normal. Then he has that usual baritone voice and the perfect diction, and everybody is like happy listening to Amitabh Bachchan's voice. So dysphagia, dysarthria will occur in all D manifestations will be given, guys, including diaphragmatic weakness leading to dyspnea and myasthenic crisis. The word is crisis. If he says the word crisis and what will you do, then for crisis, I will have to secure the airway. So if he says what is the first line intervention, my answer will be secure the airway, intubate the person. But if he says what is the treatment of choice for myasthenic crisis, it is intravenous immunoglobulins. The D features in this question are so prominent. Features are diplopia, dysarthria. Just imagine like this: eye issues, jaw weakness, vocal cord weakness, diaphragmatic weakness. I'll say that again. Eye problem, diplopia and ptosis. Diplopia is the symptom, ptosis is the examination finding. Jaw weakness, that will contribute to like dysphagia. Then vocal cord weakness, so there would be dysarthria, unclear speech, and diaphragmatic weakness that can contribute to even respiratory arrest or paralysis. That's a medical emergency, and these patients will require hospitalization. Myasthenic crisis is usually triggered. Like person might have had a respiratory tract infection, patient might have had a UTI or COVID-19, and then myasthenic crisis can be triggered. The highlight of this condition subsequently is point number 7, which is a favorite of FMG examiner, that there is a muscle weakness with normal D tendon reflexes. You see, guys, in neurology, in lower motor neuron lesion, we have a areflexia. In upper motor neuron lesion, we have a hyperreflexia or brisk reflexes. In neurology, we are always taught either areflexia or we are told muscle weakness is with brisk reflexes. This is the only example where you get a muscle weakness with normal deep tendon reflexes. Alphabet D coming up once again. Now we will focus on the screening test for this condition. The screening test should be remembered as IcePack test and should not be answered as Tensilon test, as was the case a couple of decades earlier. In IcePack test, what we do is that we put IcePack at, you can see this person is having unilateral ptosis, asymmetrical ptosis. I put an IcePack and magically after 5 minutes, the ptosis is gone. How on earth is it possible? Well, you just need to listen to the explanation here. There is an enzyme at our neuromuscular junction by the name of acetylcholinesterase. It is responsible for degradation of acetylcholine. All enzymes in our body operate at 37 degrees Celsius. If I will decrease the local temperature, then the activity of this enzyme will also become lesser. If the activity of the enzyme will become lesser, then the degradation of acetylcholine. This will inhibit the degradation of acetylcholine. And as a result of it, I said, because there is inhibition of the degradation of acetylcholine, so acetylcholine available at neuromuscular junction will be more, and therefore the symptoms will improve. I'll say this once again. I'm going to erase this data. No point of remembering this. This is just an explanation. I said when you put an IcePack like this, it is going to decrease the local temperature. All enzymes operate at 37 degrees Celsius. If you decrease the activity of the enzyme, the destruction of acetylcholine will become lesser. If the degradation of acetylcholine is lesser, there is more available at the neuromuscular junction, and more will basically cause more stimulation of receptors, and thereby the ptosis of the patient will disappear. I mean, this is very primitive data, na, ki temperature dependent activity of enzymes. We learned this in first year, that enzymes operate optimally at 37 degrees Celsius. Here what we have done is we have simply degraded the enzyme activity. I'm removing it from here because otherwise it makes the notes look a little clumsy. So I just want that sheet to be clean. But I wanted to bring to your attention the first test for this condition is IcePack test. After IcePack test, the next test to be done, the specific test to be done for this patient is to measure the antibody titer. The name of the antibody is anti-acetylcholine receptor antibody. We can measure the titer of this antibody. Another one that I explained to you was anti-MuSK antibody, after which we come to investigation of choice. Investigation of choice is one which is both highly sensitive as well as highly specific. This was again a hot favorite of FMJ examiner. I don't know why, but they've asked at the IUC for this condition, the test that is having the highest sensitivity and specificity. First we do a ISPAC test, after that we do a antibody titer. The third test that will be making it like totally watertight diagnosis is SFEMG, that is single fiber. SFEMG, single fiber electromyography, is the best test for diagnosis of this condition. If this is not in the options, then another test that we might be answering is repetitive nerve stimulation test. The test is single fiber electromyography. The next one is a repetitive nerve stimulation test. And this repetitive nerve stimulation test will be revealing what is called as a decremental response, because the power of contraction of the muscle will decrease in myasthenia gravis because the efficiency of neuromuscular transmission is lesser. So another D alphabet added to your vocabulary, that the examiner himself will literally offer you the answer on a platter, that here sir, I've written the word decremental response on on repetitive nerve stimulation. Please tell me what is the answer. The answer is myasthenia gravis. All you need to remember is the names. First is ISPAC test, then is the antibody titer, then we do SFEMG. SFEMG is usually not available in India in majority of like government setups. So an alternative test that we can do is repetitive nerve stimulation, and that is why examiner is literally offering you the answer on a platter, sir. Like, you know, you go to a 5-star, they give you a drink, sir, here is your drink, here the answer is, examiner saying, sir, here is your answer. Then he is asked what imaging modality will be done in this patient. Answer is CT chest, because I want to evaluate the thymus abnormality now. And sometimes in myasthenia gravis patients, there can be coexistence of Hashimoto's thyroiditis. Yes, guys, don't be surprised if in myasthenia gravis question he adds up data either related to Hashimoto or related to Graves' disease. I mean, women with myasthenia gravis could be having two autoimmune disorders occurring together, that is myasthenia gravis as well as Hashimoto's thyroiditis. Now, there would be certain questions in which he will begin by describing the story of a woman, and he will say that she is having bilateral ptosis. Or some guys are so influenced by that word young woman with ptosis that they answer everything as myasthenia gravis. Guys, I said asymmetrical ptosis. Now image of that man also that I described was also in like this disorder is common. In fact, this I should write here so for introducing more clarity. All autoimmune disorders are more common in young females, understandably, or the question of myasthenia gravis will begin by describing a male more than 50 years of age. So like in Amitabh Bachchan's case, he was plus 50 when the diagnosis was made. So that helps you remember it. Now what I'm saying is the question will begin by describing a female and she's having bilateral ptosis, and he will say what is the first test to be done. A lot of guys miss the word bilateral and they start answering like, sir, you had told ISPAC test, so I answered it. Answer is coming incorrect. Why? Because it is bilateral ptosis. Bilateral ptosis could be due to a maybe a tumor, or it could be due to aneurysm in the brain, and thereby I need to do a MRI head in a patient. So if he says unilateral ptosis, agreed, myasthenia gravis to be suspected, but bilateral ptosis first test is not ISPAC test, it is not antibody titer, it is not an autoimmune presentation, man. Bilateral ptosis could be neurological due to stroke, so I need to do a MRI head in a patient, because obviously it's not only stroke, it could be arteriovenous aneurysms, it could be AV malformations that could be occurring, or brain tumors which could contribute to this manifestation. Then antibiotics like gentamicin, amikacin are not safe because they cause depolarization of the neuromuscular end plate. So he will ask you which antibiotic can be given in a patient. The antibiotic that we can be using in these patients is linezolid. An antibiotic that cannot be used in these patients is aminoglycosides, because aminoglycosides have a side effect of depolarization of the neuromuscular end plate, and already the functioning of the neuromuscular end plate is suboptimal. So aminoglycosides delay or they worsen the weakness in patients of myasthenia gravis. So suppose somebody undergoes surgical treatment, person with myasthenia gravis undergoes some surgical treatment, post-operatively aminoglycosides should not be used, linezolid can be used. Then these patients are resistant to the effect of depolarizing neuromuscular blocking agents like succinylcholine, understandably, because receptors are not there. I mean, how does a succinylcholine work? It acts by depolarizing the receptors. If receptor turnover is increased and number of receptors is lesser, then the treatment will not be successful. Like succinylcholine will not be successful. Now coming to the treatment part for generalized myasthenia gravis, he will ask you like what would you be doing. So if he says what is the treatment of choice for this condition, then please don't answer like pyridostigmine or neostigmine. We will talk about drugs also, but the main treatment is thymectomy for a generalized variety of myasthenia gravis. The logic or rationale is that thymus is the main problem. Now when it comes to the drug of choice for management of this patient, then what will we do? Then our answer will be pyridostigmine. This is long acting as compared to neostigmine, so this is the one that is preferred. And along with this, we will also be giving steroids to the patient because it is the autoimmune disorder. So combination of pyridostigmine and prednisolone should be answered as complete medical treatment. Obviously, some patients will refuse to take steroids because of the side effects, because when you Google prednisolone, first search result will say that it can result in development of Cushing syndrome in a patient. So in those circumstances, like I will not answer prednisolone. Then I will say that for like management, I can be using, I mean, patient has refused taking prednisolone, so I can give azathioprine in this patient, or even mycophenolate, which are like immunomodulatory drugs that can be used in place of prednisolone. But when it comes to ocular myasthenia gravis is like only ocular symptoms. Here, the only presentation of the patient symptom will be diplopia, and the examination finding of the patient would be ptosis, which is asymmetrical if ocular symptom is occurring for consecutively 2 years. If ocular symptom is occurring for consecutively 2 years, we call it ocular myasthenia gravis. In this patient, he says thymectomy is not recommended because simply, if the neurological involvement is not so significant, if only one problem is there, then thymectomy is not to be done. Thymectomy is done only for generalized variety. For ocular only one symptom, there is no need for doing thymectomy in a patient. And then as far as the treatment of this condition is seen, we usually will be using pyridostigmine, but sometimes there can be a paradoxical worsening of the patient. Pyridostigmine can cause a paradoxical worsening in ocular myasthenia gravis. So the main drug that is used in this condition, because it's an autoimmune condition, would mainly be acting as steroids. That paradoxical worsening part, I'll not get into logic. You can go into the main videos for that. But the main message is that in ocular myasthenia gravis, thymectomy is what is done in generalized is not done. And then pyridostigmine can exhibit a paradoxical worsening of symptoms also. So steroids anyway play a role. Patient does not want to take steroids, then obviously we have backups like azathioprine and prednisolone. Now let's do a question, very interesting one, where he began by saying a woman is having proximal limb weakness for 4 months. The weakness is worse in the morning and improves after walking. You can see the change. The question is not saying weakness in the patient is more in the morning, is like occurring in evening hours. Rather, he's saying after doing activity, the weakness is reducing. Myasthenia gravis has a decremental response, but this question is telling you about a incremental response. And then he has also mentioned that examination reveals absent deep tendon reflexes. You can notice that when I was describing myasthenia gravis to you, I had told you that the person would be having preserved deep tendon reflexes. So 2 points are immediately telling me that this is not a question on the topic of myasthenia gravis. Myasthenia gravis, the symptoms will worsen after walking. The symptoms will worsen after doing physical activity, but here the symptoms are rather improving after walking. So incremental response and deep tendon reflexes are absent. Guys, this disorder is called as Lambert-Eaton syndrome. This Lambert-Eaton syndrome is associated with lung cancer, that is usually oat cell cancer, where there is a pre-junctional defect. In this condition, the amount of acetylcholine produced at the neuromuscular junction becomes lesser. The antibody responsible for this Lambert-Eaton syndrome is called as anti-PYQ antibody, and you need to remember that the response on single fiber electromyography in this patient or repetitive nerve stimulation will be showing a incremental response. The learning point is, like I can go into why also, but because this is a revision program, it will not make sense to go into that why and a long explanation. The point is, in the MCQ, if decremental response is given, worsening of symptoms on physical activity is given, you safely answer it as myasthenia gravis. But if it is opposite written, incremental response and absent reflexes, answer it as a Lambert-Eaton syndrome. Now the trick in the question can be, and this is what INISET people will do, that in Lambert-Eaton syndrome, if you do a low frequency stimulation, then you still have a decremental response. So don't be surprised, because I was telling you this now, incremental response is present and patient will improve after walking. That's okay. But if patient will make little efforts, no, then the symptoms will worsen. So you also need to be aware of the fact that decremental response can be given. If you're an FMG student, let this point go. Just remember incremental response, move on. But if you are an NESET preparer, don't be prepared for the fact that in Lambert-Eaton syndrome question with anti-PBQ antibody can be written decremental response. For FMG exam, you don't need to get into this technicality. See, in any set, it's more depth of the question. In FMG or like in NEET PG, it's a more superficial kind of data. So you can skip this if you want, but then this is an important aspect of peripheral nervous system that I have discussed before you.